that. So how do we do it? So we need to take the bispecific bonanza into community oncology. So I thought long and hard the last couple talks I've given about changing this slide. Many of you have seen this slide. I use it in a lot of my talks. I've seen other pharma companies throw it into their talks, so it's kind of interesting when I see it being recirculated. But if it ain't broke, don't fix it. I really think this simplifies the process and what we need to do. I always give the analogy of you don't, build a house from the roof down, that you have to have the bricks in the middle to give the house stability. And without these blocks and without these things being thought of and being, really looked at in detail, this doesn't work. But if you can do this, it does work and it works well. So again, you have to have a team, right? Number one, you've got to have a physician champion, and I think the nurse, you have to have a nurse champion. In my practice, my nurses rule the world, and they are the core of my bispecific team. But you have to have a team made up of the patient and a caregiver, obviously. Without them, that doesn't work. But you have to have a physician champion, and then you have to have a team made up of dedicated, unique people who are really going to help manage these patients. And, is that nurses? Is that nurse practitioners, PAs? Is it a pharmacist? Is it the research team? What does that look like? And that's very different per site. But without that team, this doesn't work very well. And you need to have that team. You also need to learn from like-minded centers, right? Centers are doing this. Community centers are doing this, and they're doing it well. So rather than kind of being like, well, why don't we ask the question, hey, how are they doing that? Like, what are they doing that we aren't doing? How can we do that? How can we learn from them? And I think really connecting, I almost wish we had a geographical, United States map of like-minded centers across the country that we could ping on, interactive and like, oh, hey, wait, Dr. Graff is in Des Moines, Iowa, she's doing this, I'm not that far away, I'll learn from her center. Like, we need to be able to be readily available to help other practices. My nurses have actually started, my bispecific team nurses, that is, have actually started helping different groups across the country build their protocols. I've built, I think now 26 community oncology groups. I've gotten fully onboarded from not even having an SOP to fully functioning outpatient treatment for patients, both in non-Hodgkin's lymphoma, myeloma, and even small cell lung cancer. And my nurses have been with me through this whole entire journey to the point now that the ancillary staff doesn't even want to talk to me anymore. They want to talk to them. So I've clearly done a good job somewhere along the line. The next step in all of this is really thinking about what your capabilities are, right? Outpatient versus inpatient. Treating patients inpatient is becoming harder. The hospitals don't want to hold beds. They don't want to help give drug. They don't want to do these things anymore. So trying to figure out how to do this outpatient really is key. And for a lot of us, I think the patients are actually safer and better taken care of outpatient than inpatient. You have to know the uniqueness of the drugs, right? These are all different. They all bring different nuances to the table. Their rates of CRS are different, the onset is different, neurotoxicity is different. They all have their own unique story to tell. And so understanding that, which a lot of that comes with time, is super important. The management plan. The management plan is so important in all this. You have to have that plan. You have to know what to do in every situation. Like I said, I've given the analogy over the years of being the new mom and leaving this detailed, dissertation for your mother, usually who's watching your child, about all the things that could go wrong and what to do and the intervention that you should do if this happens. And that is exactly what I did 3.5 years ago when I wrote the plan for our site. It's gotten us through so much, and people have asked, are you going to change it? I'm like, no, I don't want to change it. It's worked too well. But you have to have a plan for the team, a plan for the patient and the caregiver. You have to know. It's like when we were little kids and we drew, on a piece of paper in first grade of where we were going to meet if there was a fire. You knew where you were going to go, across the street, down the block, and that's what this is for. You have to know the plan in case there's a fire. And a checklist, which I will show in a minute. The checklist in our practice the last 1.5 years has become key. And I just revamped it 2 weeks ago because theme of all this is you never stop learning. You always have to figure out how to make it better, more precise, and more concise. Communication between the hospital and between your practice, right? So practices that don't at least have a hospital partner that, you can admit to if a patient has maybe not even CRS or neurotoxicity, but neutropenic fever. If you don't have admitting privileges, This doesn't work. You have to be able to have a hospital to admit to if you should need to. You need to know where your supportive meds are. You need to make sure you have supportive meds. If you're not giving prophylactic toci for myeloma, you still need to have it around in case your patient with non-Hodgkin's lymphoma has an event and you need to use it. You can't be, ordering it from the nearby pharmacy at the 11th hour. You've got to have that in stock. You have to know who has the drugs, making sure the hospital has the drugs, making sure your office has the drugs. And also, you need to know how to manage these patients based on your site's capabilities. Every site is different. I'll have a lot of people ask me, well, what do you think the greatest barrier is? Well, there's not a greatest barrier. There's multiple different barriers, and they're different for different sites. And we have to just know what they are and figure out what can be overcome and what can't. And then also the geographical location of a treating center. Really important, we can't forget this. It's like a patient, who has CAR T. You got to remind them they can't drive a car like 5 days after having CAR T cell therapy, right? And it's the same thing with a bispecific. You can't treat them and then send them 2 hours away. They've got to be close to the treating site and to the center that has tocilizumab available. So key elements, kind of just to highlight what I just said. Bispecific team. Without this, I don't know how it works. And if somebody can tell me how it does, I will take, any suggestion. But for me, without them, this would never work. Again, a management plan, a very concise management plan for the inpatient side and the outpatient side. Order sets. Order sets are also really, really important. We all have EMRs. Most of us probably have Epic. It's very important to have these so that you're not scrambling about what to do if somebody has a fever, because you might have a new nurse in the hospital taking care of your patient, right? So it's really, really important that you have concise treatment guidelines on both sides. And really cooperation between the clinic and the hospital system, as I mentioned previously, and education. The landscape is changing, the drugs are changing, and really educating on the nuances of the drugs, because you have turnover, right? We have chemo nurse turnover, we have inpatient nurse turnover. It's really important that everybody's up to date on who, especially people who are seeing these patients, right? Okay, so the checklist. And obviously this is not, this is not all of it. This is kind of just an example, but this is a checklist. So our process is that any team, like for instance, I got 3 emails today from different teams that are saying, I want to start Joe Schmo on this drug on 12/8, 12/9. And so what they do is they go and get the checklist. They have to go step by step and initial every single box. And I mean, literally from the fact that they got the right phone number for the patient and the caregiver. I mean, going through the medications, making sure they have medical equipment, making sure they have, Tylenol that's in date in their medicine cabinet. You'd be surprised on the little things that you might forget that will get you hung up at the wrong time with the patients. And so it's so important to go through all of this. Once they go through the whole entire checklist and initial it, then they send the completed checklist to the bispecific team email, and then they can load the regimen for us for Epic, and then the regimen's loaded and they can treat the patient. But they have to go through this entire checklist to make sure they've hit all the things, sending in prophylactic, allopurinol, or sending in prophylactic anti-infectives, or making sure that they set in the Dex pill in the pocket. Every possible thing that can help this patient out through this process is included in this checklist. So what are other things that we can do to mitigate the risk of CRS and ICANS, right? So I mean, education, super, super important. We need to educate so that teaching of the bispecific to the patient and the caregiver is super, super important. If a patient shows up for their teach and their caregiver is not with them, we send them home, because that patient is gonna hear hardly anything that you're saying. That caregiver needs to listen. They need to have the ICE questions given to them. They need to know what they have to do to care for their loved one. Medical equipment. They need to bring the medical equipment to their teach. They need to show they actually know how to use the medical equipment. And then we also compare their medical equipment values to the clinic's medical equipment values, so that when our nurses and our team are doing monitoring calls, we know that, oh wait, they don't really have hypotension, their wrist cuff just reads lower. Really, really important though to show that you know the differences and that the patient knows how to use the equipment. Fluids. Fluids are so important. I will stand by, if nothing else, hydration, and not, a $50 Stanley full of water from home for the patient. That's nice too. But it's really important that they get the fluids in. So we give patients a liter of fluid pre and a liter of fluid post. Now, if they're heart failure patients, clearly we have to watch what we do with that situation, but that's about knowing your patient. But we always give the liter pre and liter post no matter what drug we're giving. Pre-medication. So dexamethasone in the beginning was not necessarily the steroid of choice. We had some leniency in what we selected, but as time's gone on, I think most of us are using dex. And for us, dex has been key for the pre-medication for steroids. All patients have their pill in the pocket dose at home with refills, because in case they use it, we need to make sure they have enough, God forbid, CRS were to reoccur. Tylenol and even ibuprofen at home, but in date in the medicine cabinet. We make sure that the patient and the caregiver have the ICE questions, because we want the caregiver to be able to ask those questions of the patient if they're starting to act off. What we've also started doing is going through the ICE questions at the teach, getting their baseline ICE score and a baseline handwriting sample and scanning it into media. Then the cycle 1, day 1 of whatever drug they're getting, they get another one, and then they get another one when they leave the chemo suite after the first dose. So we have 3 baseline ICE scores and handwriting samples to be able to compare should something go awry. And for us, that's worked really well, because we have had some issues with neurotoxicity with some of the drugs we've used, nothing in what we're doing here, but there's this small cell lung cancer drug that's really fun. So very, very important. Also, we have drug bracelets that we use, and we have them for all of the disease states that we treat. Patients have them. It mentions they're a mission patient. It mentions that they're getting a bispecific and what number to call. So in case they were to end up in an ER somewhere far, far away, there at least would be information and notification of how to get in touch with us. And then pocket cards, which caregivers find to be kind of important. Obviously, you're all very much aware of, the consensus recommendations that were published, now 2 years ago, next month, which is, probably going to need an update here, but really, really important, especially the tables in the back. The tables in the back were a labor of love that, we have hanging across our whole entire office, because they're super, super important, and they help people to know what to do right away. It's almost like, okay, this is going on, this is what I'm going to do. So CRS management has a table, right? Very, very important. And then also, again, ICE questions for the caregiver, ICE questions for all the nurses in the chemo suites, on the floors, wherever your patient is. And then the ICANS management table. Again, these tables are what are in our consensus guidelines, but these are the ones that, we obviously have at Mission, because that's what we were using, which ended up in the guidelines. What are other really important things we have to think about? So infection prophylaxis, CRS and ICANS, right? Those things are kind of important during the first cycle or so, depending on the drug you're using. But the infection risk is there, right? And the longer patients are on bispecific antibodies, that risk of infection, right? We're depleting their B cells, we're messing around with their T cells eventually, the longer they're on therapy. So it's very, very important that we do not forget infection prophylaxis. And IVIG, myeloma doctors check immunoglobulin levels all the time. It's part of the regular panel. And I feel like sometimes the immunoglobulin levels get forgotten about in our lymphoma patients. And I've seen this happen. And it's like we can help our patients so much if we're making sure that they are getting IVIG when they need it. And it's amazing how we kind of forget that it's just as important as it is in myeloma. And so I think it's something we need to make sure that we're doing a better job of doing in our daily practices. Again, hydration. Hydration is so simple, and it's such a huge part of all of this. Tocilizumab prophylaxis, right? This is being done now more and more in myeloma, which really might actually help get these drugs into community more, because you have the option for toci in multiple myeloma. So I think that might be, something that will help the uptake of myeloma bispecifics in community. And really educating on the nuances, right? It's not just about CRS and neurotoxicity, but it's about, different things that can go on, myalgias or rashes or, taste changes or headaches or vision changes or, there's so many different nuances to these drugs. It's important to be aware of beyond CRS and neurotoxicity. So what does ChatGPT say about how to do this? I was kind of curious, and I wanted to know if they could do it better. So this is their plan. This is their 90-day implementation guide. Weeks 1 to 2, think about it. Can we do this? What are the strengths and weaknesses of the program? It said something actually pretty stupid, so I changed the first line. Weeks 3 to 5, build protocols. CRS and ICANS, dosing workflows, that's their number 2. That's week number 2. Week 3 to 5, that's their second thing, excuse me. Week 6 to 8, staffing and pharmacy SOPs. I almost think that week 6 through 8, staffing and pharmacy SOPs should actually be before building a protocol. Because if you don't have staff training and you don't have staff that are willing to do this and you don't have pharmacy SOPs, I'm not quite sure if building protocols is even going to make a difference if you don't have the people to do this. But this is their plan. Weeks 9 through 10, ED and ICU partnership finalization. Weeks 11 through 12, simulation drills and documentation build. I agree with that. And week 13, launch pilot with first patient. So not bad, right? But I mean, I think it's a little oversimplified, but it's a good guide, right? It's a good guide to start with. So in summary of this part, emerging therapies need structured workflows. Community practices can safely deliver bispecific antibodies. We need just to give them the tools to do it. This improves access and equity, and also patients win, clearly, right? So we talked about moving bispecifics into the community. Just for a few seconds here, let's talk about CAR T. So, pretty soon here, the bispecific bonanza is going to have, another partner in town, which is going to be the CAR T cartel, right? We're getting there. Bispecifics are a huge thing, but CAR T cells with different, off-the-shelf CAR T, more CAR T being done in the outpatient setting, we are really going to need to figure out how to be a part of this as community physicians. Oops. Oh, this is my old talk. The new one did not get loaded. Okay. Sam.
Thank you.
All right. Just really quick.
Yeah, so
I don't know why the old one was not, the new one wasn't loaded, but I just wanted to talk about CAR T briefly. I think there needs to be a better bridge between community and academic centers for CAR T cell therapy, and that was my slide, kind of talking about, what can community do to help with that, whether it's, apheresis, lymphodepleting chemotherapy in community before the patient goes and has their CAR at the academic center. Even for, eventually a lot of us will be doing this in community, but for now, how can we partner, easier? Whether it's earlier return after CAR T. I think it's a start to really bridge that gap and hopefully get our referral numbers up in CAR T cell therapy as well. So sorry that the last few slides, and you're gonna miss my last few fun pictures, but my old talk was loaded instead of my new one, so thank you.
So, Tara, why don't you stay up there so that you could do, or maybe you... All right, so I'm going to invite folks to come up to the microphone. Dr. Graf is going to be leaving, so she won't be part of the session later on, so this is a good opportunity for us to ask her questions. So I want to start out by saying, Tara, first of all, thanks for such a great talk. But I was also thinking that, do you see bispecifics, learning how to do it, as an important bridge to becoming community certified in giving CAR T therapy? Because I think that that is going to be the next issue that we're going to have to address.
Yeah, so, I've been talking to other organizations and obviously COA about this and about CAR T, how to get CAR T in the community, but they're talking to some practices that have never even given a bispecific. So I think there needs to be like a stepping stone, right? But I think there needs to be a metric, right? That you need to have been able to treat, let's say, 25 patients, and I mean, I don't mean in the hospital, I don't mean referred back from the academic center, but I mean de novo from start to finish, that you have had to at least treat 25, I'm using a random number, bispecific patients to be able to even start thinking about doing CAR T. Because if you only have treated 2 bispecific patients, how are you going to be ready to do CAR T? Like if you haven't figured out how to recognize CRS, recognize neurotoxicity, use the critical thinking skills that sometimes go into some of the drugs that we use, recognizing patterns, I don't know how you can do CAR T. And so I really do think there needs to be some type of metric in terms of, okay, we've done X amount of bispecifics, now you're ready to kind of start thinking about CAR T. And I mean, I'm making that up, I don't know what that number should be, but I do think it's important. I don't think a site should just start thinking about CAR T if they haven't done bispecifics.
So I mean, that's a great point, right? So I want to take that even one step further, that it shouldn't even just be that the practice has treated 25 patients. right? It should be that you as an individual physician should have your own personal experience. And how do you do that in a group that could be maybe a 5 or 6 or maybe even 20-person group? And there might be people within the group who are interested or people who are not. In your practice, do you guys have a strategy of saying, oh, well, we've created a team of people who are the CAR-T or bispecific people within the practice?
So that's hard because, like for me, for example, when I say a group needs a physician champion, they need a physician champion, but the weight of all of that work falls on that person. So, for instance, a few of you were at dinner with me last night, and through the entire dinner, while sitting here in Orlando, I was on the phone. And it doesn't even have to be my patient, right? It could be, but if you're the go-to person, and especially, bispecifics are one thing. When you're talking about CAR T-cell therapy, you need more than one physician on board. So I have 18 partners, right? There might be 2 other people besides me that are willing to step up and manage those patients in a pinch. But when you're talking about, starting a CAR T program, you need to really make sure you've got a decent amount of dedicated people that are going to know what's going on inside and out the way that you do. So you can't just have one random person in a group that's like, yeah, I'll do CAR T, because there's no way you can even handle the volume of how that, it's a big lift. And I'm speaking personally for the last 3.5 years of what that's been like for me.
Good. Yeah.
Tara, I have a question for you, and I also have, I'd like to call upon my nurse practitioner in the audience to make a few comments about this. But Tara, here's the question. Does it make more sense to make more community physicians able to deliver CAR T cells, or make it easier for patients to come to academic centers?
Both. I think the answer is both. I think there are some community sites that don't have the ability to do CAR T, and not because they're not brilliant physicians, but because they don't have the infrastructure, they don't have the bandwidth, and perhaps they don't want to have the bandwidth. There's different reasons. And I think we can't have community sites afraid to refer patients for CAR T. We've got to overcome that barrier. But the problem is there's this massive fear that exists that once the patient goes for CAR T, they're not coming back to their home. They're not coming back to their primary oncologist. And I think we need to that's why I'm saying I wish my slides were there. I think we need to have that relationship, that back and forth highway, more structured so the patient can go to the academic center if that's the route, and then come back to the community site, maybe within 14 days, right? An earlier return to co-manage. That's one thing. But I also think we need to train community oncologists, whether through different programs, different educational programs with the support of pharma, however it's done, to train sites to do this, to go in. Like I said, I've done 26 sites for bispecifics, and some of those sites, it took me 9 months to get ready, truly working with them from the ground up to be able to do this. But you just need to give them the tools, we said tools, that they need to do this. So I think we can train sites to do this, and for the sites we can't train for whatever reason, then we need to make the referral process and the relationship smoother between community and academia.
It's just that personally, I think the infrastructure required to perform CAR T cells, unless they become non-toxic due to modifications, is so great that absolutely sending people back home as soon as possible is a good idea, like we do with stem cell transplant now. But I don't think in the near-term future it's going to be realistic to start CAR T cell programs in geographically difficult areas.
No, it's going to depend on those, it's going to depend on those qualified, high-volume, well-trained community sites. This is not something that every community site should do across the country, absolutely not.
Ralph, I think you have something to say.
I just wanted to reiterate something that Tara brought up, and that is that I agree that both sites of service need to be in place. It will take a while before community physicians have the potential to learn these things for all the reasons that she just mentioned. But if you think about what's going on in clinical research in CAR T right now, there is a tremendous expansion in the use of CAR T now, not just in hematologic malignancies,
Autoimmune.
but there are huge numbers of patients now being treated with both solid tumors, autoimmune disorders, neurologic disorders such as multiple sclerosis. So that I think there is going to be a need. It's going to take us a while to get there, again, because this is really bispecifics on toxicity-wise, bispecifics on steroids. So I agree with you, Tara, 100% that no reasonable site should think about doing CAR T until they've really understood bispecifics, gotten their feet wet a little bit, understood and had a chance to treat both, mostly CRS, because the incidence of ICANS in the bispecifics is so low, they're not going to get much experience there, but they can get some experience with it. But as we move forward, and that's one of my charges today, is to talk about, how we can simplify some of this and what the science is doing moving forward in order to facilitate that. Just like every therapy that we've learned to do in oncology, it's going to take some time to adopt to it, as the newer therapies have a whole new set of toxicities that we never learned about until they came along.
Very, very well said. So, Tara, before you leave, one last word. I know we're out of time. One last word of wisdom on your feelings about prophylactic tocilizumab as a strategy for mitigating, not just for myeloma, but across the spectrum of bispecifics. Obviously not for blinatumomab. I don't think that anyone is doing that.
We have data, right? We have good data and different studies that have been done in myeloma. And so I think that it's a little bit more readily available. And even though NCCN puts it there, insurance companies still don't want to pay for it necessarily. But I think in myeloma, using prophylactic TOCI, especially when you're talking about these drugs being used in the community, and maybe to give more of a, okay, we can do this, more of an ease to doing the drugs, I think being able to use prophylactic TOCI is very important. Now, for non-Hodgkin's lymphoma, we don't have the multitude of studies that we do for myeloma. And I think we'll see this more and more, but right now, I would not go and tell people to start using prophylactic tocilizumab for our non-Hodgkin's lymphoma drugs. I don't think that we're not there yet. But I think for myeloma, that's different. We have the data. We see more than 50% reduction in CRS percentages when prophylactic TOCI is used. Now, does that mean every single patient needs prophylactic TOCI? I'm not sure an $11,000 drug should be used for every single patient that walks through the door, but I think if you're a newer center doing this, and especially if you're doing it outpatient, I don't think you're wrong if that's, something that you want to do to further, mitigate that risk of CRS.
Thank you so much, Tara. So before you leave, hand of applause for Dr. Graff. So we're going to be moving the program right along, and our friend from the great city of Los Angeles has joined us. When I was looking earlier, I didn't see Tysol. I said, well, there's ice in Los Angeles. I hope he had not been iced, but he's here in person. And so Dr. Tysol Phillips is joining us from City of Hope Cancer Center. And he'll be talking to us about the data that supports the use of T-cell redirection therapy in lymphomas. Without much ado, Dr. Phillips.
Thank you. Unfortunately, I have not fixed my planning snafus. Luckily, I'm still young enough to run from the Hilton. All right, so this afternoon, we'll briefly overview some of the data with the bispecific antibodies in lymphoma. We'll specifically focus just on diffuse large B-cell lymphoma and follicular lymphoma, just because of the limited data we have in other B-cell non-Hodgkin's lymphoma spaces. Here are my disclosures. And to generally level set, just to give us an idea of why we are looking for new treatments in diffuse large B-cell lymphoma, we start with the pivotal PARMA data looking at outcomes in relapsed refractory large cell lymphoma. For the most part, when we see a plateau in the curve, a lot of this is really heavily weighted by patients with relapsed disease. As we know from our clinical experience and historically that patients with refractory disease tend to do historically poor with chemoimmunotherapy and have very poor outcomes with salvage therapy with autologous stem cell transplantation. So this was more so sort of illustrated by the updated core data, specifically looking at patients who previously had relapsed refractory disease after receiving rituximab in the frontline setting. As you can see, the outcomes are abysmally poor in that patient population, more so heavily weighted by patients with refractory disease. So while we've made great strides with the introduction of the CD20 monoclonal antibody, it did subsequently have a downstream effect in sort of limiting the effectiveness of salvage therapies in this patient population, and thus set us up for the need for having other sort of treatment options. Now, this data set is what pivotally led to the introduction of CAR T-cell therapy, which we know we have 3 FDA-approved options in the third-line setting. It's not the focus of this situation, given that CAR T is more so still situated in academic centers, and the agents that we can give in a more broad sense is the bispecific antibodies. So if we look at the NCCN guidelines for third-line options for large cell lymphoma, as you can see, we see the 3 CAR T-cell options, but also illustrated here are the 2 bispecific options we have available for our patients, which are epcoritamab and glofitamab in this patient population. Now, there's been some additional information from Echelon 3 with the use of BV and R squared. We do still have selinexor listed, and there's Lintafa and also loncastuximab in this patient population. Now, the data that's supporting the introduction of epcoritamab, there's some EPCOR NHL1. Again, this is not necessarily novel information I'm presenting at this point, but it still illustrates the step-up dosing pattern for patients with large cell lymphoma. As you can see, it starts off with a slow step-up dosing to introduce the bispecific antibody. Patients started for the dose of 0.16 milligrams, then go to 0.8 milligrams the following week. Then you go to 48 milligrams, which is the full dose. And then it's 48 milligrams weekly through cycle 3. From cycles 4 through 9, it's every other week. And then from cycles 10 beyond, it is once a month indefinitely or till the cows come home. That last aspect obviously has some implications for our patients, but this is how the study was designed. Now, this bispecific antibody is given as a subcutaneous injection, so ideally it does not take up a lot of chair time specifically, but you do have to deal with injection site reactions, which is different from the other bispecific antibody we'll discuss. So this updated 3-year follow-up just indicates that a fair number of the patients who have attained a complete response were able to maintain some durability of a response. Now, the follow-up for bispecific antibodies is still relatively short compared to what we have with CAR T-cell therapy. But invariably, the hope is that with these bispecific antibodies, we will get some plateau in the curve demonstrated that there will be hopefully a subset of patients that can be cured with this treatment modality. Now, this will be important because still within the United States, we have a dearth of sort of access to CAR T-cell therapy. I'm sure if you ask any manufacturer of CAR T-cell therapy, they have about a fraction of the patients they would have expected at this point. We are still struggling to understand why we are having access issues in some areas with CAR T-cell therapy, but again, if you are in a remote area where you have not necessarily access to CAR T-cell therapy, patients don't want to relocate to a CAR T-cell therapy, the durability of responses with these bispecific antibodies will be an important option, as it may allow patients to remain within their community setting and receive some hopefully curative treatment for their aggressive large cell lymphoma. So again, just illustrating my point about the durability of complete responses. Now, again, we would hope to still see these curves out at 60 months, demonstrating some plateau in these curves. But as you can see, at least for those who are able to maintain a complete response, there is about half of the patients, a little bit over, who are maintaining some durability of response, and we'll again need further follow-up of this to sort of get some clarification. The next slide sort of just replicates that, adding in the overall survival benefit of this sort of treatment option. Again, but it's not too far-fetched. If patients are in remission, they are hopefully living longer and not necessarily dying of their lymphoma, which is the goal for any of these treatment options. Now, again, there is some subset differences, not subtly, not substantial, between what we consider diffuse large B-cell NOS, high-grade B-cell lymphoma, and some transformed large cell lymphomas, which we have some data sets to suggest that maybe patients with transformed disease do a little bit better with these bispecific antibodies than those with diffuse large B-cell lymphoma NOS. Now, the concern for most when you're using this agent is obviously cytokine release syndrome, and so we've done a lot to try to sort of mitigate the risk and sort of optimize patients to try to prevent hospitalization requirement that is necessarily with these treatment options. So with epcoritamab, the manufacturer's insert suggests a hospitalization at the first full dose, which is 48 milligrams. Now, with this optimization program where they use dexamethasone for the prophylactic pre-medications, days 1 through 4, and they hydrated patients the day before, day of, and after receipt of epcoritamab, they were able to mitigate and reduce the rates of high-grade CRS. And in some situations, they were able to eliminate the sort of requirement to have patients hospitalized in this situation. So again, possibly providing an option, especially for centers who don't have hospital bed access, to potentially give this medication and not necessarily worry so much about high-grade CRS or any CRS that will require any hospital admission. So as you can look, again, from the optimization cohort versus what we see with the standard practice, which is in the column headed by the blue marker, you can see that, again, we are dealing with mostly grade 1, grade 2 CRS, and the majority of the events were grade 1. Again, as to be expected, the highest incidence of cytokine release syndrome is with the first full dose, which is the 48 milligram dose. Now, to further sort of emphasize the ability to transfer this treatment option to an outpatient setting, there was a study that specifically looked at giving epcoritamab completely as an outpatient regimen without a hospital admission. So this is the EPCO NHL6 study. This was done in quite a few of the community sites that actually are implementing bispecific antibodies. As you can see from the median age of 69, most patients with advanced stage large cell lymphoma, and again, a smattering of second and third line setting. So as you can see from this circular plot, the idea is to try to keep these patients outpatient as much as possible. They did implement the optimization strategy that we discussed on the previous slide as a way to mitigate cytokine release syndrome in these patients. So as you can see for the 92 patients who were started outpatient, again, we did see CRS in 37 patients, about 40%. Again, the vast majority of these were grade 1, grade 2. There was 2 grade 3 events in this patient population, a median of 2 days to resolution. About half the patients were treated with tocilizumab and 41% treated with corticosteroids. 7 patients, even though they were enrolled on this study, were admitted to the hospital. As you can see to the block to the right, the reasons for hospitalizations in these patients, which are fairly, reasonable in this situation. If you have patients with poor cardiac reserve, respiratory dysfunction, or other issues, again, regardless of whether you can give this as an outpatient, you more than likely want to try to continue to keep these patients inpatient for more safety of the patients until you can demonstrate that no cytokine release syndrome. But we also see there's no hint or sort of decrement to overall response, complete response with this outpatient regimen, as this is fairly consistent with what we saw in the pivotal study where patients were admitted for most of the step-up dosing. So again, this does necessarily take away the concern for cytokine release syndrome, but for those of you who have some reservations about giving epcoritamab or other bispecifics in an outpatient setting, this does give you some sort of a template that this can be accomplished without necessarily having to incorporate a hospital bed or a hospital system in general. Now, the other bispecific antibody that was approved was glofitamab. Glofitamab has a little bit of a structural difference than what we see with epcoritamab. So glofitamab is more so structured based on the molecule of obinutuzumab. It has 2 CD20 binding epitopes, 1 CD3. It is given with obinutuzumab as a pretreatment. It is given as 1,000 milligrams the week before the start of glofitamab. Glofitamab is then given as a step-up dosing from 2.5 milligrams to 10 milligrams to 30 milligrams, and then every 3 weeks. This is given for a finite treatment period. It is given for a total of 12 cycles of therapy, and then patients are then subsequently monitored and managed. So again, this is an IV medication. It is initially started with an IV infusion around 4 hours, can be extended to 8 hours, and then go down to 2 hours. Additionally, as I mentioned, this is a finite treatment, which is different from epcoritamab, which is studied as a more indefinite treatment as a single agent. So this is more so like a 24-month follow-up masqueraded as a 3-year follow-up. But as you can see, again, with this treatment where, again, all patients are done with treatment around 8 months, there's still some durability of the curve here. We will subsequently still need longer follow-up of this data set to see some stabilization of the curve. As I mentioned, this is a shorter follow-up than what we presented in an epcoritamab study. Very similar to that design and what we already know with large cell lymphoma. If you can get a patient into a complete remission, you're much able to maintain that complete remission with these treatments. And patients with partial responses, the vast majority of these patients will subsequently have a relapse unless they actually still have complete response disease, which is maybe a false negative PET scan. So if we look at the duration of complete response by the investigative review committee, again, a little over 50% of the patients remain in the complete response and durable response at this point. The median duration of complete response of 26.9 months. For transformed patients, again, we have 28.3 months, and prior CAR T cell therapy, about 22 months. Now, Again, in the caveat of patients exposed to CAR T-cell therapy, I think all of the bispecific antibodies have demonstrated some ability to respond to patients who have previously progressed on a CAR T-cell therapy. The caveat being, obviously, these are patients more than likely that have had some sort of response to CAR T and may have lost it. So again, patient who may have response at 30 days, but if you look at 60 and 90 days, the disease has come back, versus patients who have rapidly progressed through CAR T-cell therapy. These are probably not ideal candidates for a monotherapy treatment with a bispecific antibody, as again, these patients, for some reason, do not probably have some sort of, they probably have some underlying reason to not respond to a T-cell directed therapy. Now, if we look at safety, the safety curve of glofitamab, especially specifically looking at CRS, is about an inverse of what we would see with epcoritamab. Remember, epcoritamab, the highest incidence of cytokine release syndrome is the first full dose. With glofitamab, it is the first initial dose of the antibody at 2.5 milligrams, and you subsequently see a decrease as we proceed with the subsequent cycles of therapy, and very few after the introduction of full dose therapy. As this is an IV formulation, the onset of CRS is typically quicker than what we see with epcoritamab, where the CRS onset can wane from the first 24 hours up until probably 96 hours. For most patients with glofitamab given an IV formulation, you will likely see the onset of CRS within 24 hours, again, with hopefully rapid resolution of this symptom with implementation of corticosteroids or tocilizumab. Now, a big concern with bispecific antibodies is the hypogammaglobulinemia that comes from the B-cell aplasia. Now, if this graph to the right sort of illustrates that the antibody recovery after cessation of glofitamab in this patient population, as you can see, it takes about 18 to 24 months to probably get full recovery of B-cell function and immunoglobulin production in this patient population, suggesting that if we can extrapolate something from the myeloma doctors, is that monitoring and replacement of IgG is probably an important strategy. Some people have implemented in checking IgG subtypes in patients. Again, if you have recurrent infection and a normal IgG level, sometimes if you look at the subtypes, you can see that some subtypes are lower, and you may actually be able to mitigate some of these infections with replacement of the IgG subtype, specifically IgG3 in this patient population. So this chart just summarizes what we know for the efficacy of some of the bispecific antibodies. In this chart, we haven't included odronextamab, even though this agent does not have an FDA approval within the US, but it is approved within the European countries. But again, if you can look at the long-term data set from these two pivotal studies in the study that looked at odronextamab, for the most part, we see a lot of more similarities than differences between the overall response rate, the complete response rate, duration of complete response, et cetera. So again, the real big differences between the two agents within the United States is that one is a subcutaneous formulation, one is an IV formulation, and one is a treat to progression, whereas the other one has a more finite treatment option. Now, with longer follow-up, we will be able to see if there's any progression-free survival differences between these two agents. If there is, then again, we will likely proceed with the one which supports the longer progression-free survival. If there is not, then again, it may call into question the use of the more indefinite treatment with epcoritamab, because what is the benefit of continuing to give a patient a treatment if there's not making necessarily them live longer or causing durability of remissions? Now, if we switch gears to the second line setting, which typically should be a space for CAR T-cell therapy, but, you know, obviously drug companies found a way to weasel their way into sort of any indication. So as you can see within the boxes, we have two sort of regimens that have demonstrated some efficacy in second-line large cell lymphoma. We have EPCO-GEMOX, we have Glofit-GEMOX from the STARGLO study. I'm sure we all can discuss that issue. And then we have Mosin-Pola, which was also presented this past summer. So this last summer was the study of randomized studies beating up on R-GEMOX, as we had 3 of them presented at the same time. So the STARGLO study was a 2-to-1 randomization of glofitamab given together with standard GEMOX versus R-GEMOX in patients with transplant-ineligible relapsed refractory large cell lymphoma. Transplant ineligibility is really not a criteria for second-line large cell lymphoma within the U.S. anymore, but nonetheless, this was a study criteria. Patients, again, were a 2-to-1 randomization. Patients continued the glofitamab for an additional 4 cycles after cessation of GEMOX if they completed the 8 cycles of GEMOX. So the primary endpoint of this study was overall survival, which the study did meet its primary endpoint. The STARGLO regimen showed an overall survival benefit compared to R-GEMOX in this patient population, and subsequently also showed a progression-free survival benefit in this patient population. So with the subsequent follow-up of this study, it again demonstrates further indication of a survival benefit from this regimen. And if we look at the adverse events from this patient population, there was no substantial increase in the rates and incidence of cytokine release syndrome with the addition of gemcitabine and oxaliplatin. Now, the sort of theory behind adding GemOx to a bispecific antibody is that the inflammatory reaction from the chemotherapy would hopefully trigger some benefit in the bispecific antibody. So there was some sort of logical explanation for using GemOx as a combination partner in this treatment. But thankfully, there was no increased toxicity from the cytokine release syndrome aspect. Now, from the other adverse events, there's higher rates of neutropenia and positive infection with the addition of a bispecific to chemotherapy, but those are to be expected given the mechanism of action of these medications. Now, we have more updated data set looking at the 2-year follow-up of the STARGLO regimen. And again, as you can sort of see from this sort of updated information, it continues to demonstrate that there is an improvement in the overall survival benefit from this patient population compared to R-GemOx. And again, as I mentioned, as you look at the slightly higher increased risk of toxicity. Now, the bigger question comes, obviously, as we know that this regimen was not approved by the FDA. A lot of this stems, unfortunately, from the enrollment of this patient population globally. Obviously, there was very few, if any, U.S. patients enrolled on this study, which calls into question the benefit of the regimen within the U.S. patients. Now, this is still within the NCCN guidelines as a 2-way recommendation, so you can still get access to this medication. So it doesn't take away necessarily from my ability to use the medication, but will likely frame sort of the future studies that use randomized trials globally when they're looking for a U.S. FDA approval, if that will be a requirement moving forward. Now, the next study that we can talk about is the EPCOR GemOx study. This was a single-arm phase 2 study looking at epcoritamab plus gemcitabine and oxaliplatin, again in transplant-ineligible patients with large cell lymphoma. GemOx was given in a standard step-up dosing fashion in this situation, and again, GemOx was given every 2 weeks based on tolerability in this patient population. Median age of 72, again, as you can see, median prior lines of therapy was 2. Even though this is supposed to be a transplant-ineligible patient population, you can see 10% of the patients did have prior exposure to autologous stem cell transplantation. So the overall response rate was 85% with a complete response rate of 61%. And as you can see, looking at based on prior line of therapy, the less heavily pretreated you are, the more deep and durable the responses it appeared to be in this single-arm study. And again, with a 12-month PFS rate of 69%, 12-month overall survival rate of 84%, again, suggesting, again, benefit between GemOx and a bispecific antibody. Again, this is also currently in the NCCN guidelines. It gives you another option for this patient population. Just as an aside, again, GemOx in this study was continued until progression or intolerance. So again, this was not necessarily designed as a finite treatment regimen for this bispecific antibody. Now, SUNMO was another study from Genentech looking at the combination of mosunetuzumab and polatuzumab versus R-GemOx. Now, theoretically, there's no rational explanation per se to say why polatuzumab was synergized with mosunetuzumab. I think it was just more so of a lucky sort of situation where Genentech had 2 products and, again, wanted to combine them together and see what they got, and here we are. So if you've given any of these agents, mosunetuzumab in this situation is a bit different. It's given as a subcutaneous formulation, so the dose is different from what you give as an IV formulation. So it is given at 5 milligrams, 45, 45, and then 45 milligrams every 3 weeks, which is different from what we give as an IV formulation, which is 1, 2, 60, 60, and 30. It is again given here in this situation for either 8 or 17 cycles based on attainment of a complete response. And polatuzumab in this situation is given up to 8 cycles in this patient population, but most people will limit it to 6 due to concern for neuropathy due to the MMAE payload. Now, the difference between this study and STARGLO is that the primary endpoint was progression-free survival. So this shows an improvement in complete response rate and overall response rate compared to R-GemOx. At the interim analysis, the primary analysis, again suggesting that there's a benefit to the mosunetuzumab regimen in large cell lymphoma. So again, progression-free survival, that primary endpoint was met with this study. Complete responses were also durable with this study. Again, a little bit of a caveat, obviously, is that as we discussed with STARGLO, the enrollment of U.S. patients is a very important situation. So with SUNMO, there is some data as a single-arm study with U.S. patients only, again, supporting the data set that we have from this global randomized phase 3 trial. So I think the big cherry on top for this regimen, as you can see, looking at the rates of cytokine release syndrome, the rates of CRS are much, much lower than what we see with any regimen with epcoritamab and glofitamab. And again, I think this is the most appealing thing for this regimen, especially if you sort of look as these companies try to appeal to community physicians to use bispecific antibodies even more. The biggest concern, obviously, is that the lack of uptake of bispecific antibodies related to fear and risk of cytokine release syndrome. So again, if you have a regimen with reduced risk of cytokine release syndrome, the hope is that you'll get more uptake into this patient population, uptake of these agents, into our lymphoma patients and utilize these more than what has been currently utilized since the approval of these 3 agents. So as far as other adverse events, we do see peripheral neuropathy, which is to be expected with the MMAE payload, but again, doesn't seem much different than what we see with GemOx. But again, GemOx is not something we typically will use frequently in these patients in this situation. Injection site reaction is a higher risk with this situation. Obviously, with IV formulation, is not something you have to be concerned about. But again, this is something to take in consideration, as it can cause some morbidity to the patient due to the frequency and recurrence of this injection site reactions, and sometimes they can get recall in other areas even if they get injected in another site. So again, this is just more so just emphasizing again the PFS benefit of this regimen. So again, discussing the partners for these bispecific antibodies, it does appear that there is some sort of benefit with ADCs, antibody-drug conjugates with bispecific antibodies. We're not going to show the data, but there's data looking at glofitamab plus polatuzumab, which shows a higher complete response rate and more at-risk patient population in the single-arm glofitamab study with higher rates of patients with high-grade B-cell lymphoma and double-hit lymphoma. But again, there are other ADCs that are out there in circulation. We talked about loncastuximab before, so this is a CD19 antibody-drug conjugate that has a PBD payload. So there was this LOTUS-7 study that looked at glofitamab in combination with loncastuximab in patients with large cell lymphoma. As you can see from the overall response curve, especially for those with 150 microgram per kilogram dose, the overall response rate is 93.3% with a complete response rate of 87% in this patient population. Very early data, but again, it appears that there's higher efficacy than what we have seen so far with any of the other ADCs combined with these bispecific antibodies. And again, and more importantly, if we look at the rates of cytokine release syndrome in this patient population, which is not showing up on this slide, but the rates of CRS, I think I cut it up, sorry. But the rates of CRS, especially higher grade CRS from this, was quite low. So in this study population, they had one patient that had a grade 3 CRS. The majority of the CRS events were grade 1. And this potentially will allow sort of transition of glofitamab to a completely outpatient regimen for this patient population. Now, this is being further studied and further follow-up. It is a small cohort of patients. I believe they enrolled almost 30 patients at this point. And so later in the year, later in 2026, we will hopefully get a further readout of this combination and sort of see where it fits in an overall treatment algorithm of patients with large cell lymphoma. So what's next is a bit of a headache for frontline large cell lymphoma, as we have multiple frontline studies that are ongoing and will read out shortly. What we will make of this mess, it will be, kind of difficult, but at least for bispecifics, there are 3 bispecific studies that will read out likely within 2026, 2027. One with Pola-R-CHP and GloFit, one with EPCO plus R-CHOP plus epcoritamab, and then odronextamab and CHOP. Now, lastly, we'll talk about follicular lymphoma very quickly. In this situation, as we can see historically, we can chop up follicular lymphoma into eras. The most beneficial era of follicular lymphoma was the introduction of the monoclonal antibody rituximab, which sort of coincided with what we saw in large cell lymphoma. But if you look to the right, the biggest benefit seems to be in frontline therapy. So there's a big drop-off between frontline follicular lymphoma remission durations and second and third and subsequent lines of therapy. As you can see, all those seem very much bunched together. Now, a lot of this data set is based on chemoimmunotherapy, but again, it suggests that, again, we had a lot of room for improvement in second-line plus follicular lymphoma. So mosunetuzumab was the first bispecific antibody approved in follicular lymphoma. This is approved in third-line plus. You see the overall response rate of 60%, overall response rate 78%, complete response rate of 60%. And if you look to the bar graph to the right, you see even with subsequent high-risk sort of features, we still see responses that are fairly equivalent, suggesting this is agnostic of some high-risk features and mutational aspects of patients with follicular lymphoma. Now, as far as the duration of complete response, we see the median duration of complete response at 24 months is 63%, PFS 48% at 24 months, time to next treatment 56%, and again, the median overall survival 87% in this patient population. So again, suggesting some durability of response of this treatment. And again, this is a treatment that does not require hospitalization. So unlike what we have in large cell lymphoma, there's no recommendation for hospitalization with mosunetuzumab. So looking at the safety profile, you can see there's mostly grade 1, grade 2 CRS. It's more of a U-shaped curve with the IV formulation. So you get a peak at 1 milligrams, a dip at 2 milligrams, another peak at 60 milligrams, and then subsequent reduction thereafter. But again, most of these are very mild and low grade. And this is a perfect situation where a pill in the pocket is very helpful. You send patients home with a couple doses of steroids. If they get a fever, then you subsequently have them take Tylenol and a steroid. And if it does not break, then they will come to the hospital. But for the majority of the patients, steroids and Tylenol will be subsequently enough to sort of break the fever from cytokine release syndrome. So the next one approved was epcoritamab. So again, if you want to focus on epcoritamab and follicular lymphoma, the key thing is the optimization cohort. So again, they added another step-up dose to reduce the rates of cytokine release syndrome. So you have 0.16, 0.8, 3 milligrams, and then go to 48 milligrams. As you can see when we present a little bit later, it made a dramatic reduction in the rates of high-grade CRS, and again, allowed this to be given as an outpatient without any recommendation of hospitalization. So the responses for this agent are fairly equivalent to what we saw with mosunetuzumab. Again, so we know it works. It works across some high-risk features, POD24, refractory last therapy, double refractory, et cetera, et cetera. Again, we see fairly equivalent overall response rate, complete response rate in this patient population. So what I've blocked off is the most important thing, as you see with the optimization dosing, meaning adding that additional step-up dose. You can see the rates of CRS went from 66% to 48%, and pretty much all of these were grade 1 CRS at this point, with only 4 cases of grade 2 CRS. So again, this was a marked reduction in the rates of CRS compared to what you see in the pivotal cohort. And again, based on this extra step, has allowed this agent to be given without the requirement of hospitalization. But again, as we mentioned with large cell lymphoma, this is a treat to progression regimen as a single agent. And so again, that is the sort of difference between that and mosunetuzumab. Then again, mosunetuzumab is a fixed duration, either 8 or 17 cycles, whereas so either a little over 6 months to a year versus, again, an indefinite treatment. Now with the mosunetuzumab also having a subcutaneous formulation, again, there's more flexibility there. So again, we need to see more long-term follow-up to justify, again, the indefinite treatment nature of epcoritamab in this patient population. So again, this is another summary slide just looking at efficacy and safety of this patient population, again, demonstrating some of the information we have to date with these bispecific antibodies. Again, we included odronextamab in this situation, and we also included the CAR T-cell products for some comparison's sake. So the CAR T-cell products at this point do appear to have more durability of response. But again, the bispecific antibodies, given what we have with follicular lymphoma, knowing that it is not curative as of yet, again, it is a very reasonable option for patients to go bispecific than CAR T in this situation, because we're not necessarily denying or delaying a curative treatment for patients with follicular lymphoma until proven otherwise. So this is only shown just in the last ASH. We know that this sort of came into the play, that we had some improvement on R-squared, which was based on the Augment study, which had been the preferred second-line option for most academic clinicians. Again, this improvement, adding tafasitamab to R-squared, again, showed a marked improvement of what we have with R-squared in a more heavily pretreated patient population that was demonstrated in Augment. Again, tafasitamab for all its warts, again, because more frequent dosing, especially in the beginning, then every 2 weeks, again, as a more indefinite regimen. Again, adds more visits, but again, as we can see with the next slide, had a marked improvement in progression-free survival compared to patients with R-squared. And as we know, tafasitamab does not necessarily add any significant toxicity. So again, it could have been something that could be considered, especially for patients with high-risk follicular lymphoma. Now, that being said, its sort of reign as a sort of top option was fairly short. As we know that this is upcoming ASH meeting, we will have information presented from EPCO R-squared versus R-squared. So again, most of us saw the press release with a significant improvement in the hazard ratio in this patient population. So again, this is epcoritamab given for a finite treatment duration. So again, weekly and through cycle 3, from cycle 4 through 12, once a month. It is given and conducted with rituximab for the first 5 cycles, and then lenalidomide is dosed as we would every 3 weeks on, 1 week off. And this was compared to standard dose in R-squared. As we can see from the preliminary data set that's available as of right now, we have a significantly high overall response rate, complete response rate. As you see, the PFS for the hazard ratio, 0.21. Again, there is more toxicity with this regimen, and we will find out more about this as this upcoming ASH meeting as we get more detailed information about this clinical trial. Now, for future directions, the bispecifics, we can say, are always upwardly mobile, and they'll be evaluated in frontline follicular lymphoma as well. So this is a single-agent study with mosunetuzumab that was presented by Dr. Fauci from Memorial Sloan Kettering. This is a dosing schedule for this regimen. It is given as we specifically would give mosunetuzumab, again, for either 8 or 17 cycles, outpatient administration and appropriate pre-medications. As you can see from this situation, the overall response rate of 96%, complete response rate of 80%. If you look at the sort of the plot here, it seems to be very agnostic based on high-risk features. And again, there were some patients who did relapse with this feature with loss of CD20, so that is a concern that as the more we use these bispecific antibodies, we have more antigen loss in this patient population. But again, if you look at the progression-free survival curve and duration of CR, it suggests that this is a highly durable and effective regimen in this patient population, and something that will likely be explored more in upcoming frontline studies with follicular lymphoma. So again, this may sort of push the bispecific antibodies into a frontline setting. So again, something that will eventually may be compared to what we will see with chemoimmunotherapy and some of these randomized studies that are ongoing that we'll read out very shortly. So again, as we look at this situation with the bispecific antibodies, they are coming. They're something that will be an important part of all lymphoma-related treatment. As we look at the community as a whole, it's not just going to be in heme space, as we have tarlatamab in non-small cell lung cancer, small cell lung cancer, and there are multiple other bispecific antibodies being looked at other solid tumors. So at a certain point, again, this will very much mirror what we see with checkpoint inhibitors, where we will likely have a bispecific antibody approved for almost every sort of cancer that we know to man. And it is a situation where we all will have to have a lot of familiarity with dealing with the adverse events that come with these medications and structuring our clinical practices so that we can give these drugs. Because again, as a whole, cancer isn't going away, unfortunately, anytime soon. So again, as we get more and more of these new treatments, we need to necessarily be able to offer them to our patients. So with that, that's my conclusions, and thank you. And again, sorry for being late.
All right, so with the next speakers, we're going to be using the Q&A session, which is at the end of this. But the question that I would like for you to begin to think about, Tyson, is sequencing has become one of those questions, especially with diffuse large B-cell lymphoma. Where do you see this? Maybe the studies are not out yet, but that's an important question I want you to begin to think about. So you don't have to answer it yet, but we'll talk about it later. So without much ado, I'd like to introduce our next speaker, someone who doesn't need an introduction. He is Mr. Leukemia himself, who will be joining us here today, Dr. Richard Stone, who is a professor at the Dana-Farber Cancer Center in Boston, Massachusetts. And what he will be doing today is talking to us about T-cell redirection therapy in leukemias, specifically acute lymphoblastic leukemia and other leukemia. So without much ado, Dr. Stone.
Thank you. Dr. Bire and members of the Indy Heme Education Committee, I'd like to thank you very much for inviting me to this important symposium. I'd also like to put out a great word of accolade to Dr. Bire, who's dedicated his career in part to bringing complicated but life-saving anti-cancer therapies to a large number of people who would not necessarily be able to avail themselves of such things. So kudos there. And I'll talk about a highly expensive and technological area, which hopefully will be available and is available to the community in our country and others. Here are my disclosures. I'll be talking about available T-cell directed therapies in leukemia. There's really only one if you consider acute leukemias. CD19 B-cell, ALL, can get either blinatumomab or one of 3 CAR T-cells. Those are the 4 approved T-cell redirection products in acute leukemia right now. The first use of blinatumomab was in relapse refractory ALL patients. It moved to measurable residual disease positive patients, and then to MRD negative patients. And it's being used across the board, I would say, in Philadelphia positive ALL. And of course, CAR T cells are currently approved in relapse refractory ALL, which hopefully will be a less common problem as we get better therapies up front, as you heard from Dr. Phillips. Unfortunately, the disease which I spend a lot of time on, AML, right now we have no T-cell directed therapies, and I'll spend a second talking about why that might be the case. For those of you who don't do acute lymphoblastic leukemia all day long, I'll try to tell you how we subdivide patients. First of all, whether you're Philadelphia positive or negative, I'm talking about actual having the BCR-ABL transgene as opposed to expressing mRNA and protein typical of Philadelphia positive disease. That's called Philadelphia-like ALL. So for truly Philadelphia negative ALL, no BCR-ABL, we divide it into older adults, middle-aged adults, and younger adults. In middle-aged adults, we use highly effective pediatric-like therapy, at least most people do in the country. In middle age, we're starting to get some blended regimens between the less intensity regimens, the lower intensity regimens we use in older adults. And of course, in terms of immunotherapies, which we're talking about today, about 25% of patients with ALL have T-cell ALL, and right now there's no approved T-cell redirection therapies in that subset, but there is in B-cell ALL, as I've mentioned. And in B-cell ALL, right now, although there's developmental strategies for other B-cell antigens, right now we're limited to CD19-directed therapy, which is expressed universally in B-cell ALL. Now, relapsed ALL is a terrible disease. We all know that from these slides, which are talking about the history of this disease in the last 50 years. If you do respond, though, as in many types of cancers, you can expect to live longer. So responders live longer than non-responders, not exactly stop the front page news, but still it does suggest that we'd like to get responses. Blinatumomab, you've already heard about other bispecific antibodies. This is the one we use in ALL. It does bring T cells in close physical proximity to your lymphoblastic leukemia cell, thereby causing the T cell to release cytokines which are cytotoxic to the B cell that's malignant. CD19 is a good target because it's only expressed on normal B cells and malignant B cells. And if you get rid of all your malignant B cells, you might cure the patient. If you get rid of all the normal B cells, you might have problems with hypogammaglobulinemia, but you can fix that with intravenous immunoglobulin. And Tara talked about the toxicities of T-cell directed therapies, but just to summarize them, cytokine release, which can be fatal. It's worse if the therapy is used at a higher tumor burden, so it's good to use these things when there's a lower tumor burden. In the case of blinatumomab, we step up the blina dosing, starting with a lower dose, going to a higher dose. And in CAR T cells, it turns out that splitting the CAR T cells into 2 different infusions might be a good idea, as I'll mention. Neurological toxicity is scary, awful if it occurs severely. It's less well understood in terms of its pathophysiology, and it can cause confusion, somnolence, and seizures. Hematologic toxicity, which is important, is due to the lymphodepleting chemo we need to give to the patient to allow, quote, room, unquote, for the CAR T cells to get in there. And it's also caused by cytokine storm, which is myelosuppressive and immunosuppressive. So the trial that got blinatumomab into the armamentarium for relapsed refractory ALL was the Tower trial, which is basically a decade old now. This enrolled people who were greater than 18 with relapsed refractory CD19 positive ALL. And the interesting thing about this trial to me, and you saw some examples of that in the lymphoma field, this was single agent blinatumomab, the bispecific antibody, against whatever chemo the patient was going to get the doctor wanted to give to the patient. Could include very myelosuppressive chemo like FLAG-IDA or FLAG-anthracycline, high-dose Ara-C. And the response rate was higher in the patients who received blinatumomab with the, you can see here, 44 versus 25%, and 34 versus 16%. If you consider true complete remissions, that means your counts recover. And most of those remissions were, at least with the blinatumomab, were achieved at what's called an MRD negative state, where there was less than 1 in 10 to the third or 10 to the fourth malignant cells being able to be identified by antibodies. And the overall survival was superior compared to chemotherapy. So this was a practice-changing trial. It changed our view about giving chemotherapy to relapse refractory ALL patients. And soon thereafter, led by Nicola Gockibut from Germany, people started to use blinatumomab in the minimal disease setting. These are patients who got their initial chemotherapy but still had evidence of detectable disease by sensitive antibodies or presence of the leukemia by genetic techniques, and patients who got blinatumomab in minimal disease states did better than those who did not get blinatumomab, and this led to the approval of blinatumomab as an MRD eraser, which is something that we are looking for in AML and other diseases. This was approved rapidly, and it rapidly was translated into use, into incorporation in frontline studies where it was used with chemotherapy from MD Anderson, from Italy, and from France, respectively on these slides here, showing, this is uncontrolled data, but showing a high response rate, a high survival when blinatumomab was incorporated into the regimen. So MRD positive, definitely. Maybe it should be in virtually every patient getting chemotherapy for the initial diagnosis of their B-cell ALL. But this was another seminal trial called E1910, standing for ECOG 1910, a product of the U.S. National Cancer Trial Network, led by Mark Litzow of Mayo Clinic and ECOG, who the trial actually is interesting. It started out as sort of this blended middle-aged chemo, not as intensive as the pediatric regimen and not as non-intensive as the adult regimen. They were going to give everybody blinatumomab or not. That was the original design in this trial, but right after the trial started, blinatumomab became approved for MRD positive patients. So they said, okay, we'll just check out those who are MRD negative, which is most of the patients. 224 patients were MRD negative after initial chemo, and they were randomized to blinatumomab or not. And a lot of people scratched their head and said, well, why would you give somebody blinatumomab to somebody who's already MRD negative? They don't have any leukemia, or they had such, but really what they have is minimally detectable leukemia, and they are, in retrospect, the ideal patients to get an MRD erasing drug like this bispecific antibody, because if you give it when there's very few cancer cells, you're not going to get any of the T-cell redirected toxicities, and indeed that was the case. And maybe you're hitting the disease at its most vulnerable. And surprise, surprise, maybe not if you really thought about it, just adding blinatumomab when people are MRD negative, as you can see from the control curve, wasn't so wonderful, but if you added blinatumomab to those patients, they had a markedly decreased risk of death. There were some neurologic and psychiatric adverse events, but they were largely low grade and easy to manage since it was given, as I said, in this minimal disease setting. And relapse-free survival was also superior, as was overall survival shown on the Kaplan-Meier curve on the right-hand side of this slide. And this year, the pediatricians published a similar trial showing that blinatumomab added to standard chemotherapy for standard risk ALL, so not the lowest risk, not the highest risk, but standard risk, which is the majority of the kids with ALL, it reduced the relapse rate. It's a little too early to see a benefit in overall survival, but blinatumomab will be incorporated into pediatric regimens as well. Now, this trial, which was presented by my colleague, Dr. D'Angelo, at last year's ASH, was the Alliance 04-1501 trial, which was actually trying to show that inotuzumab, which is not a T-cell redirected therapy, but rather an antibody-drug conjugate, was effective in newly diagnosed patients with CD20 ALL, CD22 positive ALL, to which inotuzumab is directed. But the reason I'm showing this is because we're now going to be using blinatumomab along with inotuzumab and chemotherapy in young adults with ALL based on the issue that occurred with this trial. Well, the inotuzumab, which is an anti-CD22 antibody-drug conjugate, produced a higher rate of grade 5 toxicities than did the control, and a higher rate of non-hematological grade 5 toxicities than did the control. So the trial had to be stopped. The event-free survival was not improved by the addition of inotuzumab, although the response rate was, the progression was lower, so the progression meaning relapse, by and large, was lower with inotuzumab. So if we could figure out a way to give the inotuzumab without the toxicity, which largely probably was due to just sort of a beat-up marrow after the chemo and the inotuzumab, maybe we could have a benefit. And so the plan, which is in the bottom left here, is to give less chemo, a little bit less inotuzumab, but add blinatumomab to all the patients. So that might be a way to use 2 different antibody-directed therapies for our ALL patients who are young adults and get good long-term survival. Now, moving to the older age group, and even the middle age, it's very hard to give pediatric-like therapy to middle-aged and older adults with ALL. And what pediatric therapy basically is, it's a less myelosuppressive, but it's more immunosuppressive. There's more intrathecal therapy, more L-asparagines, and more steroids. So what can we do about that? Well, we can dose attenuate the chemotherapy, but we still haven't, just with dose attenuated chemotherapy using legacy trials, we still have pretty poor 5-year survivals. We only cure about 20% of people who are over age 50 with ALL. But now, with the advent of both antibody-drug conjugate, inotuzumab, and with blinatumomab, we probably can use less chemotherapy and still have good outcomes in older adults with ALL. In fact, if you look at the Alliance 041703 trial there in the second from the right, that involves no chemotherapy whatsoever. It's inotuzumab induction, followed by blinatumomab. Very high CR rate. Unfortunately, the CRs in all these regimens, whether it's antibody-drug conjugate plus chemo with or without blina, that's the MD Anderson approach, or whether it's antibody-drug conjugate plus chemo, that's the European approaches there on the left. You get a high CR rate, but it's still not equivalent to long-term cure. So what are we doing in older adults with Philadelphia negative ALL, which I'm showing here, is we can add inotuzumab, as I mentioned, and we can add blinatumomab. And at least with this regimen, which is inotuzumab plus or minus blinatumomab, you can see that we are making some strides compared to historical controls. The 2 boxes on the left, the blue is the historical dose-adjusted hyper-CVAD that was used in older adults, and the top curves are the mini hyper-CVD, so no anthracycline, lower doses of all the drugs with inotuzumab, and many of these patients got blinatumomab added. And I'm going to come back to the Alliance trial, which is chemotherapy-free. As you can see, it's inotuzumab for mostly 2 cycles, followed by blinatumomab, which is given for 4 cycles, and each cycle of blinatumomab is about 28 days. And as I already showed you, the complete remission rate is very high. It's 93% CR and CRh, which means no blasts in the marrow and reasonable count recovery. And the survival and event-free survival curves from that chemotherapy-free study were just published in the JCO by Dr. Wildewut. And you can see here the overall survival is, with about 3 years of follow-up, is 50%, and the event-free survival was about 60%. So that's pretty good for an older adult with ALL. Dr. Luskin is trying to show that such an approach with inotuzumab, mini hyper-CVD, is actually better than the dose-adjusted hyper-CVAD, which is the control arm in this trial. It's fully accrued. It hasn't read out yet, but as you can see, there are lots of patients had to be greater than 50. Many of the patients are older than 70 that go on this trial. So blinatumomab, which is given to all the patients on this trial, may help improve the long-term outcome of patients with Philadelphia negative ALL who are older. So let's turn to Philadelphia positive ALL to indicate where blinatumomab may be making a difference. Well, before we had tyrosine kinase inhibitors that inhibit BCR-ABL, we weren't doing very well with Philadelphia positive ALL. And when I was in training, and for decades after that, it was a dismal disease. You had to get a transplant if you were young enough to be able to avail yourself of that particular modality. So historically, things were bad. But with the imatinib, the advent of imatinib, which we all know about now, it's about the 25th anniversary of that drug coming onto the scene for CML. Well, why not use it in ALL? And one of the first trials to throw it in the mix was the ECOG 2993 trial, which was also done in the UK. And whether imatinib was used early in the course of the regimen or later in the course, the results were clearly better than they were in the pre-imatinib era. But what's going on right now is that Philadelphia positive ALL is actually a favorable disease where chemo or very little chemo is actually required. And that's mainly due to the tyrosine kinase inhibitors, but I would also submit it's due to T-cell redirected therapy in the form of blinatumomab, which is now usually given to people with Philadelphia positive ALL. Probably the most common regimen used in the world is the so-called FOA regimen that Dr. Robin Foa from Rome brought to us along with his colleagues. And basically people get some steroids, they start their tyrosine kinase inhibitor, dasatinib or ponatinib, and then at some point, probably early on in the game, blinatumomab is added. They get their tyrosine kinase inhibitor continued, and you can see from the recent follow-up of Dr. Foa's study that in this once horrid disease, we're getting overall survivals in the 80% range long term. And whether you should use ponatinib or dasatinib as the tyrosine kinase of choice, and where and when you should insert the blinatumomab, I would say early before resistance can develop, especially if you're using dasatinib, and then whether or not the patients even need a stem cell transplant, which was de rigueur previously, and now may not be needed for many patients with Philadelphia positive ALL. So you can't forget about CNS prophylaxis. That has to be given along with the chemotherapy-free approach of the tyrosine kinase inhibitor and blinatumomab. So to summarize this part of the talk, which patients with B-cell ALL should get a blinatumomab in first remission? Well, right now, I would say all middle-aged and older adults with Philadelphia negative disease should get it based on the results of the E1910 study, and based on some of the non-controlled data in older adults that I showed you. So dose attenuated therapy is certainly feasible. It's the only thing you can do in older adults, but mini hyper CVD is a typical dose attenuated regimen used in older adults. There's emerging data that venetoclax can be added with some better efficacy. Inotuzumab can be added, but blinatumomab should probably always be added. And of course, I mentioned the inotuzumab alone induction followed by blinatumomab. And in acute lymphoblastic leukemia, as I just showed you, that's Philadelphia positive. I would give the blinatumomab shortly after we start the TKI within the first month and continue the blinatumomab for at least 4 cycles while continuous tyrosine kinase inhibitor therapy is being given. We haven't yet shown convincing data that blinatumomab should or needs to be added to pediatric-like therapies, which is encoded here as AYA for adolescents and young adults. Children, now for those with standard risk disease, based on the results of the recently published study, yes, they're going to get blinatumomab as well. So in the last few minutes, I'm going to speak about CAR T cells in ALL. Right now, the only approved CAR T cells are all CD19-directed CAR T cells. And I think we've certainly got the idea of what CAR T cells are, but certainly in the case of ALL, they're comprised of an anti-CD19 antigen binding domain and a co-stimulator domain, CD28 or 41BB, and a CD3 zeta signaling domain. And of course, you got relapsed ALL, you got to make sure there's CD19 expression. If it's negative, you can consider experiments with CD22 CAR T cells or bispecific CAR T cells. That's not ready for, they're not approved yet. But if you've got CD19 positive relapse, you can certainly consider one of the anti-CD19 products. So this is an important slide from a recent review in Blood that looked at the major trials done in CD19 ALL, relapsed ALL, with CAR T cells. And I'll just focus on the top three because those represent the key trials with each of the three available agents. Tisagenlecleucel, which was the first one, that was the Eliana trial, high complete remission rate, variable persistence, but a pretty high rate of CRS, 46%, and ICANS, 13%. Because of the way the trial was developed, it's only available in patients 25 years of age or less than 25 years of age. Brexacap-pagene, artalucel, that was the ZUMA-3 trial that led to the approval of that particular drug, had a similarly high complete remission rate. It was a different co-stimulatory molecule than the tisagenlecleucel. That was using CD28, and it maybe not quite as persistent, but the CRS rate was lower. The ICANS rate was not insignificant. Neutropenia was common, although it did persist. I said less persistent, actually more persistent. It has a high degree of absent B cells in the complete remission group. And the most recently approved drug is obicell. It's a CD19 fast on and off drug. The idea there is you don't have persistent activation of the T cell, which could reduce the toxicity. And indeed, if you look in the third column, this is the result of the Felix trial, the CRS rate of grade 3 or greater was only 2%, and the ICANS rate of grade 3 or greater was only 7%. And it was fairly persistent as the IVIG replacement was required in about 72% of patients. So you've got those three available drugs, CAR T cells and ALL. The Eliana was just for young adults, as I mentioned. It went up to age 21, but the approvals at up to age 24. All the CAR T cells use this Flu-Cy lymphodepletion to allow the CAR T cells to be taken up. And this was a single dose that was based on the patient's weight, because most of the patients on this trial were children. The relapse-free survival was an impressive 60% in these fluidly relapsed patients by and large, but it's a pretty toxic agent. Some of these patients received a stem cell transplant after they achieved a response to the tisagenlecleucel. Whether or not that's required is still debatable. The second of the three available CAR T cells is brexacap-pagene, and this is the ZUMA-3 study that got the drug approved. Again, a similar eligibility criteria, except patients of any age were allowed to go on, so that made it a little bit more widely available when it was approved. And again, you had to have bone marrow blasts greater than 5%, so not for minimal residual disease at the start. And the primary endpoint was CR/CRI by central assessment. The secondary endpoints, you can see them there. And the results were also quite favorable. Again, these patients had to have 5% or more malignant cells in their marrow, and the proportion of patients who remained in remission was good, and the overall survival was also good. You can see those who had higher degrees of response, as expected, did better than patients who did not achieve that. Finally, the last one is this very interesting Obe-cel product, which has a lower level of permanent binding to the malignant cell and is also given as a split dose, kind of the same idea as the step up in the blinatumomab dosing. You can see that those who have lower than 20% blasts got a higher dose of CAR T cells in the beginning, and their second infusion gave the rest that were available. But those who had a significant amount of bone marrow blasts at the time of study entry got a pretty low CAR T cell dose, 10 million, and got the rest of the 400 million after as a second dose. The proportion of those that remain in event-free survival is similar to the other products, and the follow-up is about 17 months, as I mentioned. Who gets CAR T cells in ALL right now? Pretty much all relapsed patients, but major controversies are present, of course. Should we be giving this at the time of MRD positive relapse or wait for morphologic relapse? Obviously, I think it goes without saying if we're allowed to do it at MRD positive relapse, that would be ideal. Of course, now that everybody's getting blinatumomab in the upfront setting, will the natural history of relapsed ALL change such that there'll be fewer CD19 positive relapses that might be eligible for one of these three agents? And maybe we can incorporate CAR T cells, especially if we're successful, as we talked about earlier, in getting them into the community. Maybe we can incorporate CAR T cells in place of blinatumomab because they might be more powerful than blinatumomab in first complete remission. Of course, which product to use? We have three choices, really only two for people over age 25 should we use. Obviously, the Obe-cel, the most recent one, is intriguing because of its lower toxicity profile. And do we need to consolidate with an allogeneic stem cell transplant? Still a very tough question. Some people look at the IVIG level, the immunoglobulin levels, and if the immunoglobulin levels are low, indicative of B-cell aplasia, possibly due to persistence of the CAR T cells, that might be an indication that you don't need a stem cell transplant. And of course, we're trying to mitigate toxicities. I'm not going to go through this slide in detail, except to say that there's a host of ideas, bispecific CAR T cells that are better at releasing cytokines in a more rational fashion. And of course, the whole idea of using T cells for CAR T cells for T cell ALL is a very open question. We need to do something to prevent fratricide because the CAR T cells would, if they were CD7 positive and the CAR T cells were active against CD7, obviously you need to get rid of the CD7 on the CAR T cells. And there's several ways to do that, actually, using CRISPR technology or other things to prevent CAR T cell CD7 expression. And finally, why are there no CAR T cell expression yet in AML? We could spend a long time on that, but I'm out of time. But we don't have a great target, or sometimes the target's present on too many of normal cells. That's a sink. The biggest one is that myeloid cells are different. The same cytokines that kill the B cells might be food or make the myeloid leukemia cells happier. There's ways around that, but I won't go into that due to time. So I hope I've given you a little taste of how we use T-cell redirected therapy in the clinic in B-cell ALL right now, and I'd be happy to answer any questions later.
Thank you so much. So before I call on our next speaker, again, a question that I'm thinking of, Dr. Stone, is twofold. One is that as we begin to deploy, blinatumomab in patients with ALL traditionally has been such a rare disease, and maybe you could insist that a lot of the patients could be treated in, highly specialized centers. But as you have patients now needing blinatumomab, even when they're MRD negative, those patients being referred back to their referring physicians, do you think that it's time for, practicing clinicians to begin to learn how to deploy these agents in the clinic? Not for right now, Richard. So this posing the question now so that later on when we do a session,
I'll remember it.
Don't worry, I'll remind you. And so without much ado, I guess this is the Boston party. I won't dare call it the Boston Tea Party. But joining us from the other side of the campus of the great Harvard University is Dr. Nikhil Manshu, who is professor in the Division of Multiple Myeloma. And he'll be talking to us about T-cell redirection therapy in multiple myeloma and how to use it in a community setting. So thanks again, Nikhil.
Thank you so much, Dr. Bere, for inviting here and this very important topic of how do we bring these treatments to community practice. And in United States, in the academic center, we treat basically 5 to 10% of the patient at the maximum, and 90% patients get treated in community. So bringing it to the patient this is a very important topic and consideration. So these are my disclosures. Now, in myeloma, there has been a tremendous progress. If you look at what has happened in the last 20 years, we have 20 new drugs approved by FDA for clinical use. And if we look at what's going to happen in this decade, there is expected to have 15 new drugs approval just in this decade. 7 are already approved so far, so we are on track to reach that target. And what this has done is made things a little more complicated in how to select, how to sequence, and utilize these drugs. Now, what we have achieved so far with these many drugs is that there has been the initial drugs, around 7 to 8 good ones, carfilzomib, pomalidomide, daratumumab, they achieve 30% response rate. The drugs are approved. We are incorporating into our induction regimen, etc. What has happened since with the new drugs, the immunotherapeutic drug, the response rates are significantly higher. They are between 60 and 95%, and they last for quite a substantial period of time. And these new 6 drugs or therapies have changed the landscape of how we treat the patients and how we take them to the community practice. So there are 2 CAR T cells approved for myeloma, as you know well. First one is ide-cel. It, in very late stage, 5th line and beyond, has an overall response rate of close to 80%, and 40% patients achieve complete remissions with very manageable CRS and neurotoxicity. The second one is cilta-cel. In the CARTITUDE-1 study, it showed response rate of 98% with 83% patient achieving complete response. So deep responses and almost everyone responds. And the toxicity is also very manageable with CRS and ICANS, except there was also added toxicity of late neurotoxicity or non-ICANS neurotoxicity, which we keep in mind and try to mitigate. Now, if we look at what is the impact of these responses on outcome, meaning survival, compared to pre-CAR T-cell time for similar 5th line treatment, overall survival used to be around 12 months. With the CAR T-cell, ide-cel gives around 30 months of overall survival, and cilta-cel almost 60 months, 5 years of overall survival. So significant prolongation, and that's why these treatments are becoming standard of care at various stages. As they work well in late line treatment, 5th line and beyond, now they have been investigated in earlier line. In KarMMa-3 study, ide-cel was evaluated as a 3rd line, and you could see that compared to standard of care, there is a significant improvement in PFS and similarly significant improvement in overall survival, with toxicity at earlier stage remaining very similar. And this has led to approval of ide-cel as a 3rd line and beyond treatment, so after 2 prior lines of therapy. Cilta-cel, with its higher efficacy, was evaluated also in an earlier line, in the 2nd line actually, and it provided a very significant improvement in PFS, similar improvement in overall survival, with toxicity also being very manageable. And now it is approved as a 2nd line treatment in patients with myeloma. So right after the first relapse, we could utilize cilta-cel. Now, this is controlled studies. What happens in real life is the real world data, and we have an accumulated data in this setting for both ide-cel and cilta-cel. You could see cilta-cel has a higher overall survival benefit compared to ide-cel. This is not a randomized study, so comparison is not truly correct, except just to put data that both the CAR T-cell provide significant improvement in overall survival. And if you look at toxicity, again, not a randomized study, but there is a higher level or higher burden of neurotoxicity with cilta-cel compared to ide-cel. Both the therapies being commercially available now for our use. Moving on to bispecific, we have 4 bispecific approved in myeloma. 3 of them are targeting BCMA, which are teclistamab, elranatamab, linvoseltamab, and then the 4th one targeting GPRC5D, talquetamab. They have various nuances for their efficacy, etc., and toxicity, which I'll go through a little bit later. But if we look at the efficacy of this bispecific, you could see that all of them provide almost 60 to 70% responses. Half of them, 40 to 50%, are complete responses. And if you look at their impact on progression-free survival, it ranges from 12 to 18 months, significantly more in this very advanced patient population. The overall survival ends up being from anywhere between 20 to 30 months. So again, significantly better, but less than what we see with CAR T-cell. And that helps us decide how to use, what to use. Again, for bispecific real-world data, reasonably mimics the study data. Overall responses with all the 3 BCMA targeting bispecific being in the range of 50 to 60%, and CR rate is slightly lower, around 20 to 25%. Again, toxicity profile remains similar in real-world data. So access to this agent poses few questions for the community practice. The first is sequencing of immunotherapy. Should we use bispecific first, or should we use CAR T first? The second and the central issue for that decision is, does use of any one of these impact the response and PFS with other? So if we use in patients with prior BCMA targeting drug, what is its effect on CAR T-cell treatments versus BCMA bispecific versus non-BCMA bispecific? And then the questions such as, should certain treatment be used or not used before we collect and utilize immunotherapy? And are there combination immunotherapy which may be more effective and preferred? So the first question, the prior exposure to BCMA targeting therapy and on the efficacy of BCMA-directed CAR T-cell. If you look at ide-cel, and this is a standard of care ide-cel used in real-world data, you could see that prior exposure to BCMA decreases the responsiveness to an extent to CAR T-cell, although 74% was also very similar to the overall data within this standard of care treatment. Those who did not have BCMA exposure had a higher overall response rate of 88%. And you could see there is a difference in PFS, especially, and those who are exposed has much lower PFS. And a similar data exists now also for cilta-cel. Prior exposure to BCMA decreases overall response to 70% compared to 92% in those who had not had prior exposure, and impact on PFS is also observed with prior exposure. So we have to keep that in mind. On the other hand, if we look at what scenario would provide improved or decreased response following prior BCMA. So if you wait long enough, can we then use CAR T cells following? And as you see here, for both ide-cel and cilta-cel, if the washout time between prior exposure to BCMA-directed treatment and then using CAR T-cell is longer, those patients are likely to respond, versus those who are shorter, they are not. Same true for cilta-cel. On the other hand, if you look at how long the prior BCMA treatment was, if that is longer, the patients are less likely to respond. If it is shorter, then there is a higher chance that that particular patient would respond to CAR T-cell. So we have to keep this in mind as this is being incorporated into our community and clinical practice. On the other hand, if you look at bispecific, prior exposure to BCMA-targeted treatment has some effect, but limited, on bispecific antibodies. So if you look at overall response, 63% overall response with prior ADC, we have one, Blenrep as a antibody drug conjugate, CAR T cells, or ADC and or CAR T cell. It ranges between 53 to 55%, so slight reduction in overall response. Similarly, if we use non-BCMA targeting treatment, the responses remains higher. So you can switch the target and you have better outcome. But the effect on PFS is quite significant. Compared to 11.4 months, it goes down to 4.5 months, and even for non-BCMA targeting, it goes down to around 8 months. So based on some of this data, our IMWG, which is our working group for recommendation and consensus guideline, has come up with certain guidelines on what to do. So there is no concern about what preceding therapy could be utilized before T-cell redirecting therapy. Could be proteasome inhibitor, immunomodulator, anti-CD38 antibody. They're all acceptable. We need 2 weeks of washout. If bispecific is used, 4 weeks of washout. We should avoid drugs that can impact T cells, alkylating agent bendamustine. Bridging therapy should be considered, and assuming equal access, we prefer BCMA CAR T cell for both efficacy, toxicity purpose to be utilized before BCMA bispecifics. So if this is the guidelines, which are the patients and which selection criteria should be used to refer patients to CAR T cells. There are 2 CAR T cells available, as I mentioned, so patients with 1 or 2 prior line of therapy can get either cilta-cel with 1 or ide-cel with 2 prior lines of therapy with both exposure to PI, IMiD, and anti-CD38, and needing refractoriness to lenalidomide for cilta-cel. Patients could have progressive disease or not adequate response to prior treatment would be eligible. We don't have age limit. We have treated patients over above 80 with CAR T cells without having great issues. And patients should be willing to follow closely. And we'll come to this in regards to community help in managing these CAR T cell patients. Cardiorespiratory problems are not very considered significant, unlike what we used to use it for autologous transplant ejection fraction. Specific number is not decided because we can go below 50 as they are relatively safer. Renal dysfunction is okay. Creatinine clearance of 30 or above we can utilize, but we have to decrease the dose of lymphodepleting drugs, especially fludarabine, for better control. And then active viral infection should be considered as a situation where I would delay the use of CAR T cell till that is controlled, especially because of immunosuppression that happens. Specific adequate bone marrow function is not required. However, if it is lower, then patients are likely to develop a longer-term cytopenia. And patients should not be on immunosuppressives because that can impact both CAR T and or bispecific efficacy. Prepheresis considerations such as not using certain treatment is an important component for selection, and bridging therapy should be almost considered now mandated. And based on that, we have also guidelines for what and how to select the bridging therapy. It is based on disease burden and also patient's disease progression. High disease burden, using bridging therapy to decrease the burden decreases the neurotoxicity in our patients. And for that purpose, avoid agents which are refractory previously so that there is less impact on CAR T-related adverse events. What is happening is that utilizing non-BCD targeting bridging therapy, such as talquetamab, is becoming commoner, and I will show you some data on that because it is quite exciting. And then anti-CD38 antibody or immunomodulators may improve the outcome in this patient, but a longer washout should be considered. Now, if you look at the role of bridging therapy, patients who respond to bridging therapy or at least have stable disease, for example, have a better outcome following CAR T compared to those who do not. And again, less than 25% decrease versus more than 25% decrease in myeloma parameter provides better outcomes. So effective bridging therapy, dual role. One thing it may select for patients or suggest patients who are responsive but also on the other hand, decreasing tumor burden is beneficial. Using talquetamab as a bridging therapy is an important component. It's a short period of time. Patient hardly gets 1 cycle to 1.5 cycles. But even with those short exposure, response rates are 62% in one of the largest studies with around 63 patients treated in these regards. And overall response rate to CAR-T also is quite substantially improved with 50% patients developing deep complete responses. For community practice, I think there is importance for monitoring some of the toxicities. Within 2 to 4 weeks, patients return back to their primary referring oncologist, and their knowledge about CRS, sometimes late, but neurotoxicity, but importantly, the late neurotoxicity is critically important. Also very important is management of infections, both identification and management of infectious complications. And then there is a standard algorithm of at what time patients should be followed weekly in the first month to 2, and then monthly thereafter. Between 3 and 6 months, they can come every 3 months for follow-up, even to the local physicians. An important criteria for now for us and excitement is that these CAR T-cell treatments are exceedingly effective. And a 5-year follow-up of the CAR-T1 study shows that at 5 years, still 1/3 of the patients are progression-free, which for our leukemia and lymphoma colleague may not be a big deal, but for myeloma, having 5 years, 1/3 patient not progress is a very great step in the right direction. And these are the patients who had 5 previous lines of treatment on a median. Now, so sequencing of immunotherapy, if patient is relatively fit and not having an explosive disease relapse, then they go for CAR T-cell. That's what our standard algorithm is. And with or without talquetamab bridging. If patient is not fit and or has an explosive disease, we need to do something quickly, and has not had any BCMA targeting treatment previously, then that patient will be getting BCMA bispecific antibody. If patient has been exposed, then talquetamab may be our next line of treatment. When patients relapse from BCMA CAR T cells, they would get talquetamab unless the remission period is more than 9 months, in which case they can get BCMA bispecific, and relapsing from that, they can get talquetamab, which is alternate target, and then there are multiple options available in future, including soon to be approved, hopefully, a CAR T-cell targeting FcRL5. Now, if you focus on BCMA bispecific and its selection, there are 3 BCMA targeting bispecific which are approved, and there are minor differences. 2 of them are subcutaneous. The third one, more recently approved, is linvoseltamab, which is still intravenous. The step-up dosage, there are differences. And then the frequency of dose. For example, teclistamab is weekly, and at a much later time, it is changed to every other week. Elranatamab, shorter, but given at 2 weeks interval, eventually going to 4 weeks interval. And linvo can be quickly changed from 2 to 4 weeks. So frequency matters. This algorithm is continuing to change because of the infection-related complication, and they're becoming less frequent as we move forward. Now, outpatient administration of bispecific has become an important component for us. We can do it, and because of that, we can take it to community practice much easier and much quicker, so that after short outpatient period, they can all go back to the referring doctor. This is possible because bispecifics in at least myeloma have a very limited and safer toxicity profile. The high-grade CRS is not observed. CRS is observed in anywhere from 50 to 70% of the patient, but they are early grade. Neurotoxicity is very uncommon. The biggest problem ends up being infectious complication. Nothing acute, but patients have reasonable issues, activation of CMV and others, and that requires a good local management by the physician. One of the things that is also becoming useful, as Remo mentioned earlier, is that prophylactic use of tocilizumab may be useful in every study with all the 3 bispecifics. The frequency goes down to less than 20%, also of a lower grade. It's not incorporated as a standard practice because of the inconvenience of use, the expense of its use, and 50% of patients may never need tocilizumab. However, patients, if they are older, they are sicker, they are frail, we do use now routinely prophylactic tocilizumab to make it safer. But infection management is a critical component with the bispecific targeting BCMA. 70 to 80% patients develop all grade infections, almost 40 to 50% develop grade 3. Hypogammaglobulinemia occurs quite universally in all BCMA targeting bispecific. GPRC5D does not impact the normal plasma cell, and that's where we do see lesser frequency of hypogammaglobulinemia. Management, we have standard algorithms developed. For bacterial, everybody gets IVIG, quite often irrespective of what the IgG level is. For viral prophylaxis, everybody routinely gets acyclovir. Now for IVIG, as you can see here, use of IVIG significantly reduces the bacterial infection and all infection, and it improves the outcome also in one of the main Majestic 1 study. And then for viral infection, as I mentioned, acyclovir for fungal infection, azoles are given routinely, although not to everybody, on a selected cases based on the higher risk of developing such complication. Now, one of the things we have realized very clearly earlier on now that reducing dose and frequency of bispecific decreases the infections rate. And so for teclistamab, for elranatamab, and for linvoseltamab, decreasing dose decreases infection, you could see in all these three settings. And so we are beginning to decrease the frequency first, not the dose, from weekly to every other week to once or every 4 weeks within first 3 to 4 months' time. And it is done with an intent that if patient responds, we would decrease the frequency. So what is the ongoing new developments that you will either see in this meeting or in next year or so? We are beginning to use combination. A very interesting data being presented for combination of teclistamab with daratumumab as a late-breaking abstract showing very great efficacy in the early line for this combination. Similar data is now generated for bispecific with CELMoDs, iberdomide and mezigdomide, and also CAR T cells with maintenance. Again, maintenance with iberdomide and maintenance with bispecific. So CAR T bispecific combination in tandem are will become important therapeutic algorithm. And then combining two bispecifics, so combining GPRC5D targeting and BCMA targeting bispecific, the tactile combination provides 95% response rate, and we are quite excited about some such similar combination with other targets. And finally, dual targeting CAR. We have a CAR in investigation that has both targeting for BCMA and GPRC5D, and then trispecific. And just to give one example finally about trispecific, you could see that using a BCMA GPRC5D targeting trispecific antibody, we get close to 100% responses. There are deep responses with high CR rate and VGPR rate. Also, we can see a very good early curve for PFS. So stay tuned for such trispecific. We have trispecific with BCMA and CD19 in investigation. Trispecific, of course, with GPRC5D is in investigation. Trispecific with CD38 and BCMA, and similar such combination with other targets, including FcRL5. So quite a good excitement about using trispecific to improve the outcome. And so finally, what's our concept for curative treatment in myeloma? We are calling it total immunotherapy. We start with an induction with immunomodulators and with agents that are immunogenic cell death inducing agent. Also, there could be induction that contains bispecific instead of 4 drugs. There could be 4 drugs where one of the drug is bispecific. Consolidation with either anti-BCMA CAR T cell or depending upon how it pans out, the anti-GPRC5D Arlo cell consolidation. And then for maintenance, again, alternating use of bispecific, again, targeting BCMA, GPRC5D, or FcRL5. And having this for a fixed period of time, probably 2 years, could become a 3 years curative treatment for myeloma. Some of these early studies are already beginning to start, and so in next year or two, we may have some idea about the depth of response, and MRD ends up being our central endpoint. So I think I will stop here. Thank you very much.
Thank you so much, Dr. Munshi. Dr. Balogi was right after all. Total therapy is here to stay. So what I'd like to do is introduce our last speaker, who is not the least, but this was deliberate because we felt that we were going to have him and I bookend this meeting. And he is my brother from another mother, the great Dr. Ralph Boucher.
Thank you, Ramo. So the first thing you probably notice is I'm one of the few that doesn't have a tie on. And the first thing I want to do is I have two disclosures. My first is that I specifically did not want anyone to think that I was going to compete with Dr. GQ. So anyway, it's great to be with you folks tonight. And I think you know the focus of this is really how do we bring more of these T-cell redirecting therapies to the community. So the speakers have done an amazing job talking about the efficacy of these new drugs, these new therapeutics, I should say. And we know with all the clinical research going on right now that more and more of these are going to become available to us. And so being able to mitigate some of the toxicities may allow us to actually bring them into the community. Tara Graff talked about her experience building her program 3 years ago. My experience is a bit different. So as a transplant fellow at UCLA, I cut my teeth on the rare patient who, when marrows recovered after transplant, developed CRS. That was my first exposure to CRS. After the NIH, I went into community practice where I am right now and built a very robust clinical trial program. And from 2018 through 2022, we had 3 outpatient CARs, 2 RNAs and 1 mesenchymal CAR. We then became part of the Mosun trial and the NHL6 that Dr. Phillips actually presented to you. So I was on the steering committee for that outpatient epcoritamab study for DLBCL and follicular lymphoma. Was actually the first site open and the first 2 patients accrued. The point I'm trying to make here is that experience really does matter when you try to do some of these things, and I would encourage anyone that has the opportunity to participate in clinical trials. It really gives you a roadmap and an experience that when some of these therapeutics are actually approved, you already have the experience and it's easy to do that. So with these experiences, we hope now to be able to build things out even further. My task today is really going to be to speak toward the therapeutic and the potential prophylaxis of the CARs to see if we can further develop a way and a roadmap to actually bring them to the community. So these are my other disclosures. So why? I think you've already learned at some of it already. CAR T therapeutics offer this really dramatic responses but do carry these unique toxicities. CRS, ICANN, prolonged cytopenias, hypogammaglobulinemia with infection, and organ dysfunction. You've heard that already. It's important to have prompt recognition so that we can manage especially the CRS and the ICANN because we can manage those people. And requires a coordinated effort like you've been hearing all along, especially Tara's elaborate discussion of how she built out her program and how to do these things, but it requires a village to actually take care of the sicker patients when they do develop. So it's important to do anything we can to reduce those toxicities and prevent it. So what is the CRS pathophysiologic pathway? It's as the CARs expand and grow, there's a rapid release of massive amounts of cytokines, IL-6, IL-1, interferon gamma, GM-CSF, an activation of macrophage which amplifies the cytokine storm. This unfortunately then causes an endothelial activation, capillary leak, hypotension, hypoxia, which results in these toxicities we're talking about and can result in multi-organ dysfunction. ICANS, on the other hand, is a cytokine-driven endothelial activation that disrupts the blood-brain barrier. These neurotoxic cytokines then can penetrate the CNS, especially IL-1, IL-6, and interferon gamma, cause microglial activation and neuroinflammation, and can lead to severe cerebral edema, and can occur without CRS. Most of the time it tends to follow CRS, but it can occur without it. So are there timelines and risk factors? The answer is yes. CRS typically occurs earlier than ICANS when either of them occur, typically within the first week as the major expansion of the CARs occurs. ICANS can follow CRS a little bit typically later, and unfortunately, as you've already heard, late neurotoxicity, especially in myeloma CAR T treated patients, is a potential problem that we're still wrestling with right now. The risk factors are high tumor burden, high CAR expansion, and some of the constructs of the CAR themselves. What does CRS look like? And again, you've already heard fever, hypotension, hypoxia, and organ dysfunction. We grade it 1 through 4, and you heard some of those discussions already today. ICANS can result in confusion, altered mental status, word-finding difficulty, seizures, and up through headaches and cerebral edema. And we have an ICE or a CREST score that we assign these patients as we monitor them very closely after infusions. Just as a very broad overview, CRS of grade 1, and I'm going to talk a little bit more about that in a second, just requires supportive care. Sometimes we'll give steroids, and more often we're even doing that to try to preempt CRS by just giving the pill in the pocket you've already heard. Grade 2, we begin to add tocilizumab. Now we've already heard some of the discussions about prophylactic toci, and I'm going to talk about those coming up in a minute. And oh, by the way, I'm mostly speaking now about the B-cell lymphomas and myeloma, not really ALL. Grade 1 ICANS, we just monitor closely, and again, you could consider I mean DEX, and we often do. Grade 2 or more, we're giving higher dose steroids. We're often now monitoring them in the hospital. We may ask for a neuroconsult. We may put them on prophylactic Keppra, and in those who need more, anakinra. So what are the grading scores for CRS? Grade 1 is a fever only, 38 or higher. Grade 2 is a fever and either hypotension that responds to IV fluids, or fever and low flow oxygen. Grade 3 is now where, and you're often putting patients in the hospital, although some now what we're trying to do is treat some of these patients in the clinic, at least for the day, and then admit them to the hospital if they don't actually resolve. Grade 3 is they're in the hospital, they're in the ICU, they're getting monopressors and or very high flow oxygen, and grade 4 is where they're on multiple vasopressors and or intubated. So what's important in the general management is early recognition and continuous monitoring. You heard earlier about remote monitoring, you heard about the caregivers, you heard about both looking at the vital signs with blood pressure, pulse, and temperature, and having, doing an ICE score with these patients, especially early on. Supportive care helps. Giving IV fluids helps. You've already heard that. We hate to get to grade 3 or 4, but the high flow oxygen and vasopressors are occasionally necessary, and that can be escalated from there. So in general, more specifically now for CRS with grade 1, again, it can be fluids, antipyretics, obviously Tylenol that you heard, and you monitor closely. Steroids, if not already used prophylactically, and a lot of us are using steroids now on day 1, 2, and 3, so that may or may not mitigate things, and there is data to suggest it can. Toci, 8 milligram per kilogram, plus or minus the low-dose steroids by grade 2. If you haven't already used them prophylactically, grade 3 and grade 4, like I said, they're in the ICU, they're getting high-dose steroids, they're getting tocilizumab, you put them on Keppra prophylactically, and you may need to consider anakinra if they are not responding very quickly. In general, we use the ICE or CREST score. The ICE score for ICANS is a 10-point system with 5 key domains that include orientation, naming, following commands, writing, and attention. You can see here the grades. So you start off with 10, and then you deduct points as you see some of these things actually occurring. Grade 1 is an I score of 7 to 9, 2 is 3 to 6, 3 is 0 to 2, or any seizure that occurs, and unfortunately grade 4 is coma. The treatment is for grade 1 neurochecks. Consider putting them on Keppra. You want to avoid TOSI as much as you can, because otherwise you're introducing basically more into the central nervous system that can make the ICANS worse, and you certainly want to at least consider DEX. We would typically give a single dose of DEX if somebody comes in a little whiffy or we see them virtually, and often that's all it takes. Grade 2, you want to start a higher dose of steroids. Often that's twice a day or sometimes more. You may want to consider a neuroconsult. Grade 3, you're on high dose steroids. You're doing things like EEGs. Certainly have them on Keppra. They're in the ICU. You've got a neurology consult. In grade 4, that's a real problem, and anakinra may also be something that could be used then. For refractory, the anakinra that I just mentioned, which is an IL-1 receptor inhibitor. For more refractory cases, siltuximab, an IL-6 inhibitor, and obviously they're in the ICU at that point in time. You've already heard that cytopenias are common. Remember that these patients get lymphodepleted to start with Flu-Cy, so already they may be somewhat neutropenic or cytopenic from their prior therapies. Now you're giving them lymphodepleting therapies, so early neutropenia after infusion is common. Unfortunately, prolonged neutropenia after CAR T therapy is not uncommon, and that would be somewhere between the 2nd to the 4th month. Generally speaking, if the patient has CRS, we try to, as I mentioned, avoid cytokine therapy because it can only exacerbate the CRS. You've also heard that infection risk and prophylaxis is important. B-cell aplasia occurs, so IVIG is important. Repeating later on their vaccines, even though they may have B-cell depletion, they still have the T-cell activity that the vaccine can help with. And then, of course, prophylaxis against PCP and some of the herpes virus is important. We now have these prophylactic strategies: prophylactic steroids, preemptive or prophylactic tocilizumab. Prophylactic anakinra is undergoing studies right now, and Keppra prophylaxis is something to consider and varies by institution. So preventing or prophylaxing CRS and ICANS is now under quite a bit of study. The goal is to reduce the incidence and severity of it and allow us now to be able to consider doing these safer in outpatient setting. Most of the bone marrow transplant centers that do CAR T, which are the original centers, FACT certified and everything else, have now moved their CAR T programs to outpatients, but unfortunately, that's not the community model. Those that are doing it from the bone marrow transplant centers are really hospital-based programs. So, for instance, in my area, the IPOP, or inpatient-outpatient program at Hopkins, the building is right at the hospital, essentially, so that's not the community model that you and I practice with. So that's something that we're trying to get over by mitigating some of these toxicities to allow us to safely be able to treat our patients. So reducing the incidence of both CRS and ICANS is a priority right now. So the approach is early immune modulation before the peak CAR T activation and the cytokine storm that occurs, that is the CRS that we see. And the question is, how do we position drugs such as dexamethasone and tocilizumab to help us mitigate some of those toxicities? So steroid prophylaxis is something now that there's good data for. The riskiest patients and the ones that you probably definitely want to consider seriously with are those with a high tumor burden or those who have early cytokine elevation. So you're measuring C-reactive proteins, you're measuring ferritin, that gives you an idea of a release of these cytokines. Anyone who's had prior CRS or earlier cell therapy ought to be considered for that. So you may be doing CAR T in a patient who previously had a bispecific and had CRS during a bispecific. And those who had inadequate cytoreduction by bridging therapy, since we're using a fair amount of bridging therapy in those patients, especially with diseases such as DLBCL, that at the time of relapse have often very aggressive disease. And you know, this is part of a new strategy of standard of care. So the steroid prophylaxis for CRS is low-dose steroids to reduce the inflammatory response. And as I was saying before, often it can be given on day zero, which is the day of infusion, day 1 and 2 after that. Used cautiously to avoid impairing the CAR T expansion, and can reduce the fever and hypotension in these high-risk patients. Dexamethasone is often given orally in addition to IV, once or twice a day for the first couple of days after infusion. The goal is to reduce, again, that cytokine peak without suppressing the expansion, and escalate only if the CRS escalates. Beyond that, for ICANS, it's, as we talked about, driven by the endothelial activation and the permeation of the blood-brain barrier. There is no medication right now that can prevent ICANS. Steroids may reduce that potential, but there's nothing that actually mitigates it, unfortunately, to date. And again, the high-risk features for ICANS are high disease burden, early CRS progression, high ferritins or IL-6s if you happen to be measuring them, and high-risk CAR T constructs. We can use steroids to reduce that. Low-dose steroids can reduce this neuroinflammatory process with Dex, as I mentioned, 10 milligrams daily times 3. It's definitely recommended in those with high risk. It needs to be escalated at the first sign of neurotoxicity if you're already giving prophylaxis, and again, does not eliminate but may reduce the severity. So early toxicities and early stage decisions can be made to mitigate the CRS and neurotoxicity using the prophylactic steroids. In the cohort 6 ZUMA-1 study, prophylactic corticosteroids and early corticosteroids and or early tocilizumab use post-infusion definitely decreased the incidence of high-grade CRS down to just a few percent compared to the other arms of the study that actually didn't include it. In ZUMA-1 cohort 3, a similar sort of thing where we saw the incidence was reduced, especially for CRS, down to about 3%. The ICANS was not really affected. In ZUMA-24, which is ongoing right now, dexamethasone is given again on the day of infusion, day 1 and day 2, and of the early part of the study, of 30 patients that were treated with axi-cel and evaluable, 90% had CRS, but it was all grade 1 or 2. There were no grade 3s and 4s. 77% had IgANs, and it was lower at about 23% compared to the 30s for grade 3 and 4 in some of the other study. And the onset was slightly delayed as expected, despite the 3 days of the steroids. Prophylactic TOCI has now been studied, and there is some NCCN guidance there. In a small cohort of patients that was reported in blood in November, there were no grade 3 or higher CRSs in patients treated 1 hour before CAR T with tocilizumab. In another study that was published back in the Annals of Hematology in July, in patients that were older than age 70, again, by giving them prophylactic TOCI, there was essentially no grade 3 and 4 cytokine releases. So tocilizumab and ICANS, again, we can treat the CRS, but we are still a little bit behind, unfortunately, in the ICANS. IL-6 may accumulate peripherally, which possibly will worsen the CNS inflammation, and it's not recommended as ICAN toci not recommended as ICANS prophylaxis because it can aggravate it. So again, consideration for tocilizumab should be in high tumor burden patients prior to admission to infusion, high-risk CAR-T constructs also, and patients unable to tolerate any hemodynamic instability to reduce their incidence would obviously be important. So we give 8 milligrams as prophylaxis now, 8 milligrams per kilogram as a single dose prior to the infusion. Some people would give it right afterwards. Some might give it at day 1, but it should be, again, the earlier, the less chance of this massive cytokine release, and then it's a therapeutic at that point in time, not a prophylactic, and you want to monitor for masking fever. Vital signs need to be on the morning of the prophylaxis. You heard about IV fluids. You heard about being in the clinic and monitoring these patients. You want to watch out for masking fevers when you give the steroids, and watch the trend of the inflammatory markers, the ferritins and the CRSs. So again, now monitoring immunoglobulin levels, treating those patients prophylactically, especially if they have IgG levels less than 400. After CAR-T, remember the immunizations are still important. Early evaluation of protracted and late cytopenias, and monitoring patients for that, monitoring patients, especially those who at the bone marrow biopsy have clonal hematopathies such as CHIP and CCUS, important in predicting outcomes, and enhanced post-CAR-T cancer screening. These patients have a higher incidence of second malignancies and early application of CAR-T therapy. So I only had 20 minutes, where the rest of my colleagues had 30, so I had to kind of race through that. But anyway, thank you very much.
So for those of you who stayed, we appreciate you. And for those of you online, there are lots of people online. Please send your questions. And so without much ado, I'm going to go to some of the questions that I raised. But I'm going to start with you, Ralph. So 2 things I'd like to bring to attention here is that you did this with experience as a previous transplanter, as someone who's done bispecifics. So you didn't just wake up one day and say, well, I'm going to start giving, CAR-T therapy in Maryland.
That's true. I'm not quite sure how to respond to that. So the answer is yes.
Okay.
I think that was the message I was trying to convey.
Yes.
That in research, I mean, the experience there's nothing like that. That's why, when we look at our colleagues out there and new therapies come along, we know that there are early adopters and there are late adopters. And the late adopters typically are those that are reluctant to try the newer therapies because they don't have experience with them. They can read the toxicities. They fear some of the toxicities, but touching it during clinical trials because you feel a little safer, you've got that roadmap, and there's nothing that substitutes for that in my mind.
So Dr. Stone, I told you I wasn't going to forget the question. So the question was, in this era of almost all B-cell patients, if not all, B-cell ALL patients needing some sort of blinatumomab, even, in remission, how do you foresee this being deployed in community practices?
Well, I think that I'm going to call on my nurse practitioner to, why don't you come to the microphone for a second, because she has a lot of experience in with the development of blinatumomab. But the answer is the ECOG 1910 study, which showed that blinatumomab was beneficial in MRD negative patients, was done in community hospitals all over the country. So it can be done. Number 2, I would say that there's going to be new ways to give blinatumomab. One of the biggest problems with it is a continuous infusion for 28 days, which is not simple, but there's probably going to be a sub-Q blinatumomab like there is for some of the other bispecifics. But Eileen, do you think it's feasible to give blinatumomab in the community easily?
Easily, no, but can it be done? Yes. When it first got approved, even smaller cancer centers, people who did not do the clinical trials, wouldn't take this on. Part of it is the cost, part of it's the fear, part of it is they don't have the pharmacy infrastructure to make the blinatumomab. It does now come in 24, 48-hour, 72-hour, no, 96-hour, and the week-long bags. But not everyone has that ability. Epic needs to be written specifically for each way you give it. It has to be started inpatient and then be transitioned to the outpatient setting. So from that infrastructure part, it's a difficult process, especially for disease. It's not common like myeloma, lymphoma. We're very limited to how many adult, I can only speak for adult, ALL patients that are seen. So that's another caveat, that the numbers aren't there to always get that experience. I think the toxicity profile of Blina, people now do feel more comfortable, but even in our place, we have events that happen. People live far away. If they go to a local emergency room, they're freaked out in that local emergency room of how to deal with a continuous infusion chemotherapy. Some of them just turn it off. That's not the right thing to do. You have 4 hours to restart it. So there's all those things that, there's a lot that goes into it, but if people are willing to and the infrastructure's in place, I think it can safely be done with the right training and the right circumstance.
No, thank you for your insight. But I think the fact that bispecifics have become a reality of life potentially makes, because blinatumomab has been around for a long time and was the only kid on the block for so long but now there's so many other kids on the block that people will have to learn how to babysit all the kids on the block. So, Taisel, I'm going to jump to you because now you talked earlier about the EPCOR R-squared data, which is expected to be presented, but it's already approved, and that is earlier in line for follicular lymphoma. And how do you foresee this now becoming the option in community practices where most patients with follicular lymphomas are treated? You're not expecting to see every patient come to the City of Hope, where soul and medicine is mixed together.
Yeah, no, definitely not. So I don't necessarily know if it's a regimen that needs to be given to every patient with follicular lymphoma. Obviously, until we see the data set, we don't necessarily know the breakdown versus with certain patient risk factors. And as we know, follicular lymphoma is such a mixed bag that, some patients can get away with just rituximab, some patients radiation, some patients you don't need to treat at all. I do think maybe the biggest obstacle, at least is what we can see from a lot of so-called rural data sets and on market analysis, is that maybe convincing some community physicians just to use R-squared, because I think its utilization in follicular lymphoma is far less in community sites than what we do in academic centers, where, we reflexively give it in a second-line setting if we haven't given it first. And so to say that they're going to jump from, not giving R-squared to giving R-squared plus a bispecific when, they're not really giving either, I think that's a far stretch. I think eventually, once we get to the point, and to my point, moving into the frontline follicular lymphoma setting, it will be something I think that if the data set plays out, it will be something that likely could replace chemoimmunotherapy and maybe something that we should consider for all our patients who actually need treatment with follicular lymphoma at some point.
I have a little question. I'm Barry Brooks. I'm from Texas Oncology. We have large community practice. We have 2 transplant sites in Dallas, and we're going to do about 150 CAR-Ts this year. But there's something you guys didn't talk about that we're having trouble with, which is this is more work for a physician than any other therapy in the history of malignant hematology or cancer. And it just wears docs out. And so you guys need to put that into your talk. Say, those of you who would be CAR-T physicians need to understand that, how tough it is to take care of an AML patient? This is much harder. And so I'm just telling you, we have literally experienced non-lazy hematologists who do not want to participate just because it wears their ass out. And I just think you guys should kind of put that into the equation at some point. Everybody thinks they want to do CAR T. Everybody's talking about doing CAR T. You need to tell them that this is not for the faint of heart or somebody who really likes to sleep.
Well, let me stay on the microphone. Sure. I want to take this further, right? Sure. Do you think that maybe this is an opportunity to educate ASH as an advocacy organization to go to the payers to say maybe there ought to be separate codes for management of these patients, because these are unique patients, and after all, an appendectomy patient is not managed the same way as a patient who's had a WIPO procedure.
You're reading my email. So with bispecifics, we have what I refer to as incredible logistic toxicity. Dr. Graff called it operational toxicity, but it's logistics and it's staff toxicities. And all the burden on staff that are not reimbursed by payers is enormous, right? And that's bispecifics. CAR T is worse, probably by a factor of 2, at least, maybe 5 in the high-risk patients. And we're being badly reimbursed at a physician level because you just don't get paid with regular E&M for all the work you do and all the things you do and all the calls you take. APPs do a lot of this work at our place, but still, the docs end up having to answer a lot of questions, doing a lot of work, and you're exactly right. We're working with payers and trying to explain to them that what they're doing right now is not adequately reimbursing physician time or thought or lack of sleep.
Can I make a comment about that?
Yes.
I think that's what you say is really touches on the sociology of medicine. If you're in an academic center, you're big enough, you're going to find a cadre of physicians who want to do this, who become expert in this. At Dana-Farber, we have a PALS survey, called PALS. I don't know what that means, but it's something to do with people who want to do CAR T cells. And they're trained in it, they're certified in it. If you're in even a big Texas oncology practice, you're making your buddies who may not want to do this, when they're covering, do it. So I think that's a lot harder.
It is.
And that's why, I asked that question earlier about whether this should, and I'm not trying to take away business from you, but that's.
No, listen, you're reading our mail. We're doing it successfully. Our outcomes are excellent, but we literally have a subset of our hematologists who are willing to do this, right? I mean.
And do you have enough to cover the nights that you need to do?
We do. Yeah. We have a lot of docs. We got 600 docs at Texas Oncology. We're big, but but we don't have 600 docs that want to do CAR T. I'll tell you that, and because they learn in a big hurry covering their buddies just exactly how much work this entails. And I think it's something ASH ought to be talking about. They didn't talk about it much with the bispecifics, much to my chagrin, and CAR T is worse. I mean, we need to be paid more for taking care of these complex therapies.
So we'll continue this conversation. Otherwise, we'll be stuck here. So thank you so much for your question. Before we get to you, I want Dr. Monti to make a quick comment on this very topic of the amount of work, one is CRS not occur, and the fact that we have data that potentially giving tocilizumab does not affect efficacy, it might increase costs. So what is wrong with a physician who says, you know what, I don't want to deal with CRS, I want to give tocilizumab to decrease toxicities in my patients with multiple myeloma?
Yeah, I think there is absolutely nothing wrong. And I think actually right before this session, I was talking to somebody and I said, give TOSI before giving your bispecific. And in your practice, you can do it. I think there is nothing wrong with it. It should be reimbursed. Expense of giving TOSI and preventing CRS might be less than person getting a CRS and whatever we do with it, except the insurance company has to give the first time this little amount of TOSI. So I think we should encourage, we should educate, and incorporate so that patients are safer and community practice can easily do it.
Thank you for the great talks. I'm from Central Coast, California, And I've done mostly academia in my practice previous, years, but now I'm doing a community practice as well. So I have the both areas that have some sort of feelings about which actually patients can be treated locally, which patients should be referred to tertiary centers. I think it depends on whether the practices or whoever is interested in doing more, maybe sleeping less at nights. It's just basically based on the particular physician's interest in how to treat their patients. Whether this could be done here or there, but I think it depends on the infrastructures and all other things. So this shouldn't be a really big question. I think the question is, who wants to lead on that, who wants to really take the responsibility, who wants to have enough experience, who wants to put more attention. I mean, it's just a matter of physician preference. But I think my question is really about the stem cell transplant. We don't know exactly whether the role of stem cell transplant as compared to bispecifics or CAR T cells is a discussion, whether we should totally sort of omit the 50% cure rate with autologous transplant in relapsed lymphoma, chemosensitive, or doing autologous transplant in multiple myeloma when they have the relapse, if they have this pre-relapse stem cells collected and stored ahead of time. So those are really my sort of first question. Then I have a few other questions.
So we have 1 minute left, so you only have one question, but we will talk afterwards. So 30-second answers from Tyson and from Dr. Munshi. 30 seconds. Look at the clock.
So CAR is already proven to be better than auto transplant, and for that situation, that's why we don't typically do autos in most refractory second-line patients. The only data we suggest that auto may be useful is retrospective, and that's only if a patient responds to chemotherapy, which is limited.
In myeloma, there is a randomized study which will result soon, where transplant is randomized to CAR T cell. MRD being an endpoint, I'm almost certain CAR T will win, number one. And number two, transplant with induction regimen where we get very high MRD negativity is becoming less anyway. If you get MRD negativity, transplant doesn't contribute as much. So I think transplant is not being phased out, but becoming less. And I think some of that space will be taken by CAR T.
Thank you so much. You're welcome to talk to the faculty. Please, a round of applause for our faculty. Thank you guys for staying, and see you next year.